good afternoon, good morning, good evening. I would like to welcome you, dear colleagues and friends from different part of the world, and especially on our colleagues here in different regions of Saudi Arabia. Welcome to the 8th annual Saudi Hematology Oncology Nurses Conferences, um, given to you by Saudi Society of Blood and Marrow Transplant in collaboration with EBMT, which I have by my side is Ms. Michelle Kenyon. Every year, as SSBMT celebrates its anniversary, it dedicates the second day for our 24/7 heroes in the healthcare institution. Do you have any idea who are those unsung heroes? Well, they are the nurses. So let me share this passage that I have read. According to American Nursing Association, today's nurses are the glue that holds a patient care journey together. And across the entire patient experience, and whatever there is someone in need of care, nurses work tirelessly to identify and protect the needs of the individual. From the beginning to the end of life, we, nurses, plays an incredibly important role in providing vaccination in schools, home health care, giving chemotherapy, and infusing stem cell product. And our responsibilities varied and diverse. So due to the vast range of specialisms and complex skills in the nursing profession, each nurse will have its specific strengths, passions, and expertise. And with the strong leadership of Dr. Ahmed Al-Askar, the president of the SSBMT, together with the officers and the board of members, even we are in the pandemic, it did not hinder SSBMT to continue research, training, and education of the healthcare workers. Now we are currently doing it on an online platform. As we have mentioned, as Dr. Al-Askar mentioned yesterday, we are in collaboration with the EBMT for the last 7 years. As we continue to grow and adapt in these challenging times, this program today, we will have 5 hours with 9 distinguished national and international speakers going to give their fresh insights with different topics in line with the nursing perspective. There will be 3 moderators to handle each session, and each speaker will be allocated with 25 minutes for his or her presentation and followed by 5 minutes of Q&A. As I look forward to your active participation, as well as bringing your expertise to our meeting, staying engaged, and shaping the success of the 8th annual Saudi Hematology Oncology Nursing Conference. Once again, welcome and thank you for your attention. Best of luck to the conference, and it is with my great pride to introduce the president of the EBMT Nurse Group, Ms. Michelle Kenyon, to give her welcome remarks.
Thank you so much, and thank you so much to SSBMT for inviting us to share this afternoon and this evening and perhaps this morning in this exciting programme. I'm absolutely thrilled to be able to be here in this, my first meeting in my new official role as president of EBMT Nurses Group. So thank you so much. I'd like to share with you a little bit about the EBMT Nurses Group and a little bit about the work that we do. Our sort of vision, our overarching theme is to promote excellence in patient care through international collaborations, and this is a beautiful example of that through education, through research, and through science. We play an essential role in hematological and in stem cell transplant nursing. And the group was created more than 35 years ago now. We have over 750 members in more than 60 countries worldwide. And we have a principal nurse identified in almost every EBMT centre. EBMT Nurses Group's mission is to enhance the value of the nurse's role all over the world, supporting and sharing knowledge and through this enhancing communication, advocacy, research, training and education. Our group is dedicated to improving the care of patients receiving stem cell transplant and cell therapies and works towards promoting excellence in care through recognising, building upon and providing evidence-based practice. Over the last 2 decades, our community of bone marrow transplant nursing has really grown rapidly, and we have to acknowledge the role that we as nurses play in the care of patients, their families and donors. And of course, no more so have our roles been important and pivotal than over the last 15, 16 months, while we have all joined together in fighting the coronavirus pandemic and protecting our patients throughout that. Advanced practice nurses have been taking a leading role in the care of patients and providing really holistic care. Transplant nurses are involved in decision-making processes about treatment options for their patients as true advocates, and they evidently contribute to an enhancement in their patients' quality of life. More and more, the EBMT Nurses Group are conducting research on topics based within clinical practice and formulating their own research agenda within the society and within the bone marrow transplant community. We're a board with 5 committees of research, global educational, scientific and communication, networking, and we link with a whole range of national groups and forums. And we are delighted to be here. Welcome everybody to this meeting, and I wish everybody a great success. I now move on to introduce our first speaker.
Then.
Thank you, Annalie. I now move on to open the first session and introduce our first speaker, Dr. Inge Gewertz. Inge is a hematologist in training at the University Hospitals in Leuven in Belgium. And at the same time, she's finishing her PhD, looking at the identification of novel targets in the treatment of T-cell ALL. She's very curious, and she loves to learn constantly about the technological state-of-the-art diseases and their treatments. And her special interests really lie in the genetic background of hematological disease and its implications for the prognosis and treatment of patients. Today, in this our first and opening session of our meeting, Inge will focus on acute leukemia. I'd like to just add, before I bring Inge to start her presentation, please use the chat function on Zoom to be able to post your questions. Thank you.
So thank you for your kind invitation. Let me first start by sharing my presentation so you can all follow what we will be talking about today. So if I'm correct, this should pop up now. All right. So I'll be giving you an update today about acute leukemia. And actually, yeah, let's get started. So the big question is, what is acute leukemia? And to get started, I first looked it up on Wikipedia. And I know that this website is generally a bit frowned upon for not being very scientific. But in my experience, it's actually a very good place to start to get to know a subject. Also, it's written in a language that everyone will understand. And this is important if we want to explain, for example, a diagnosis to a patient. Wikipedia says that acute leukemia is a family of serious medical conditions caused by uncontrolled growth of malignant blood cells. The official WHO classification defines acute leukemia as the presence of more than 20% of blasts in the bone marrow. Blasts are immature blood cells in a very early stage of development. So normal blood cells, they arise from a stem cell, and the stem cell divides and it sets its daughter cells off to develop, or what we call mature, into normal blood cells. And you can see in this illustration that this can happen in a myeloid direction, and which are the cells on the left, or it can go in a lymphoid direction, which are the B, T, and NK cells on the right. And the cause of leukemia is actually the accumulation of genetic defects while a blood cell is developing, from a stem cell to a mature blood cell. And depending on where in development this cell derails from its normal purpose, a leukemia will be more or less differentiated, and it will be of the myeloid or the lymphoid type. Sometimes a cell will look a bit like both, and then we call it something like mixed lineage, but actually means we don't really know. There are many different subtypes, and in the past, these were all classified based on morphology. So actually what a cell or a leukemia looks like when we look at it under the microscope. More recently, we switched towards a classification based on the genetic defects that we can observe. Now, this is a very complex table. The details are not really important, but you can see that we actually have three major subgroups. And on the right, we have the different AMLs. On the left, we have B and T ALLs, and then the acute leukemias of ambiguous lineage. There's many different subclasses, and these are more than just labels that we stick onto a patient. They actually are important because they predict the outcome of a disease. Now, what does an acute leukemia look like? How do these patients present themselves? Well, typically, acute leukemias have a rapid onset. So usually patients have been ill for no longer than a few weeks. The symptoms they present with are the result of too little normal cells. They give lots of hypo, so anemia, thrombocytopenia, neutropenia, a general image that looks like bone marrow failure. But there's also too much malignant cells, and this can give rise to an enlarged spleen or liver, or very high blood cell counts. Now, I love these cartoons because they really capture the stereotypical AML and ALL patient. If you put them side by side, you can immediately see that there's many differences between these patient populations. Let's have a look at the myeloid leukemias. So the typical patient is an older adult, and the median age at diagnosis is 68. You can also see them referring to our rods. What are these? These are actually typical morphological findings in the laboratory when we look at AML cells. Within AML cells, we have a younger group of patients, and they more frequently have what we call a de novo AML. So this is a disease that just appears out of the blue. Other adults, older adults, more frequently have secondary AMLs, and they are the result from previous cancer treatments or pre-existing diseases like myelodysplastic syndrome. ALL basically is a pediatric disease. It's the most common childhood cancer between 2 and 5 years of age. And if you look at the age distribution, then you will see that about 50% of patients are over 20%, 20 years of age. So they're basically your typical adult population. Compared to AML, more bone pain and more joint pain are observed. And in children, this typically results in a limp, or children that refuse to walk. We see enlarged spleens and enlarged livers. Also, we see lymphadenopathy more commonly than in AML. We see more central nervous system involvement. So this can present as paralysis of cranial nerves, or headaches, or even seizures. And 2% of boys with a new diagnosis of ALL have testicular involvement. Now, how do we make a diagnosis of an acute leukemia? Well, by definition, they need to have more than 20% of blasts in the bone marrow, which means that upon suspicion of an acute leukemia, we obviously need to perform a bone marrow analysis. We need to confirm our diagnosis, but we also receive information about the lineage of the acute leukemia, and it gives us the material for genetic evaluation of the disease. In ALL, cerebrospinal fluid analysis, so a spinal tap, is absolutely necessary. And if there is a suspicion of extramedullary involvement, you also can perform PET-CT. Now, the genetic evaluation is becoming more and more important. It allows us to classify the leukemias, as you have seen in the table I've shown you earlier, but it's also important for prognosis, and it gives us some tools to choose the right treatment for our patients. So it's a new and additional tool for a personalized approach in diagnosis and management of acute leukemia. The management of acute leukemias, there I would first of all like to spend a few minutes on the medical emergencies, because I think it's very important for you as nurses, because you stand even closer to your patient than we do as doctors, and your observations can alarm us to the development of a medical emergency. This can really make the difference between life or death in these cases sometimes. So first of all, we have hyperleukocytosis, which is actually the presence of white blood cell counts that are extremely high. And this causes leukostasis, so occlusion of the microvasculature because of increased blood viscosity just by the sheer number of white blood cells, but also the reduced deformability of blasts when compared to normal cells. And there's a direct interaction between the blasts and the endothelium. What do you need to look out for in these patients? Dyspnea, chest pain, neurological symptoms like confusion, somnolence, headaches, but also tinnitus or impaired vision. And sometimes you can even see limb ischemia. We can try to prevent it with hydration, a quick start of leukemia-directed treatment, but sometimes we need leukapheresis, so the mechanical evacuation of these white blood cells from the bloodstream. Another one is the tumor lysis syndrome. This is the result of spontaneous or treatment-induced destruction of leukemic blasts, and this releases all kinds of toxins into the bloodstream. It's actually laboratory diagnosis based on abnormal levels of potassium, uric acid, calcium, and phosphorus. It can be managed by hyperhydration, so we give lots and lots of IV fluids and some preventive medication. And then we have DIC, diffuse intravascular coagulation, which is a clotting disorder. And these patients have increased tendencies to form intravascular blood clots, but on the other hand, they also have low platelets and platelet dysfunction, which will cause them to bleed more easily. A specific entity is the acute promyelocytic leukemia, or APL, previously known as an AML-M3. And this, in this condition, we can see really life-threatening coagulopathies. These patients have a very high risk of dying from hemorrhage, typically intracranial or pulmonary bleeding. And this occurs in up to 1 in 3 patients even before treatment can be started. So in these patients, you really need to be on the lookout for bleeding gums, nosebleeds, gastrointestinal hemorrhaging, excessive bruising, and petechiae. And in the lab, you will see very low platelet counts, but also reduced fibrinogen. Now, the treatment for all patients should be based on, first of all, supportive care. So we need to manage infections. They can be bacterial, fungal, or viral. We need to give them transfusion as needed. Make sure we have tumor lysis prevention. We need to manage pain, fever, nausea, mucositis. These things can occur because of the disease, but they can also be side effects from the treatment that we will give them. And often an upgrade to an intensive care unit is necessary. Now, one thing I would really like to stress is that every patient, but also their families, really need to have the appropriate psychological support when they're going through this process. Now, the treatment depends really a bit on your patient profile. So if you have a young and fit patient, the intention of treatment should really be to cure your patient. This is done typically with a backbone of intensive chemotherapy. And if possible, we add a targeted treatment to this. For AML, the goal of your treatment should be to get your patient to allogeneic stem cell transplant with as little disease as possible. So we have typically an induction and consolidation chemotherapy, which are quite heavy. And then we hope that they are disease-free and get them to stem cell transplantation. In contrast, for acute lymphoid leukemia, we have much longer treatment schedules, alternative phases of chemotherapy, and this will last for more than 2 years in general. Stem cell transplantation, on the other hand, is not always required. Now, this backbone of intensive chemotherapy for AML is classically a 7+3 regimen based on 7 days of cytarabine with the addition of 3 days of daunorubicin. There are some alternative regimens that are used where we add additional products to this backbone. For ALL, we have some very effective pediatric treatments. Patients up to the age of 40, which we call the adolescents and young adults group, they should be treated with pediatric inspired regimens to give them the best possible chance of a cure. The alternative regimen is typically frequently used the hypercivet, but all these ALL schedules, they have rotating and repeating cycles of combinations of different chemotherapeutic products. Very important is that the intrathecal chemotherapy, so the chemo that we administer through a lumbar puncture, is an essential part of treatment of ALL. Elderly patients with acute leukemia, they can also achieve complete remission with intensive chemotherapy, but this comes at a cost of very high treatment-related mortality because of toxicity and infections. So often they are unfit to receive this treatment. And then for AML, we have some low-intensity chemotherapy products where we often can add targeted treatment. For ALL, we also have a reduced intensity chemotherapy option, the mini hypercivet, a bit like the mini chops that we give to lymphoma patients, where we leave out the anthracycline to avoid cardiotoxicity of the chemotherapy. But interestingly, for ALL, more recently, some studies have shown nice results with chemotherapy-free regimens. My personal take on the disease update in leukemia is that I believe that we're moving towards a more and more personalized approach, and an important development here was the development of new treatment options. In AML, we have Vyxeos, which is a liposomal formulation of cytarabine and daunorubicin. So these drugs are contained in tiny fat droplets to prevent premature degradation, and the dose in which they are contained is optimized for a maximum treatment effect. This is approved for therapy-related or MDS-related changes, AML. And we've also seen the development of inhibitors and immunotherapy, as well as in ALL, where we also have CAR T cells. If we look at the inhibitors for AML, then we need to look at the genetic background and the mutations that these patients have, and about 30% have mutations in FLT3, where we have we can make use of RIDAPT. Midostaurin is a FLT3 inhibitor, which blocks an essential survival pathway of the myeloblasts. They have limited single drug activity, so they're always used as an add-on treatment to chemotherapy. Importantly, about RIDAPT is that it has gastrointestinal side effects, so it can cause nausea, vomiting, and diarrhea sometimes. It can also cause rashes. On top of that, a nice thing to know is that the blisters of RIDAPT, they interact with the coating of the capsules, and this creates quite a pungent smell for your patient who's probably already nauseous. So you can put these tablets or these capsules in the fridge, and this really helps to make it easier for your patient to take them. Now, second class are the IDH1 and 2 inhibitors, which can be used in about 20% of patients, approved in relapse setting, and studies in first line are ongoing. This induces differentiation of blasts, so it forces your myeloblasts to become more normal or more mature cells, which can also cause a differentiation syndrome, which you may also know from APL. So it's characterized by chest pains, dyspnea, you can see hypoxia, and you should also be aware of sudden weight gain in your patients. And then finally, and very recently also, we have the BCL2 inhibitor, which can be used already in elderly patients. This induces apoptosis, so these cells undergo forced programmed cell death. And studies are ongoing to move this to first line as well and enlarge the population of patients in which it can be used. For ALL, there are very few inhibitors that have been developed specifically for ALL. Typically, we repurpose inhibitors that are available for other diseases. And there we can use the ABL1 inhibitors. You may know these molecules from patients who have chronic myeloid leukemia. And there we have already uh, quite a large choice. The Philadelphia-like BALLs, there we have clinical trials ongoing to see if we can treat them with JAK inhibitors, both always as an add-on to chemotherapy. And then specifically for TALL, also the BCL2 inhibitor Venclixto that I talked to you about on a previous slide is being explored in a clinical trial. So I think that this arsenal will increase in the coming years. And then we have the other backbone, the immunotherapy. So this is actually typically the use of monoclonal antibodies in acute leukemia, and they target surface antigens on the blast cells. The anti-leukemic effect can be either the result of cell-mediated toxicity. When the antibody binds to the blast cell, it plants like a little red flag on this cell that attracts normal immune cells to kill these blasts. But an antibody can also be used to deliver a drug specifically to a blast cell. And we do this by attaching a drug molecule to the antibody, and this is called an antibody drug conjugate. And an example of this is Mylotarg, the gemtuzumab ozogamicin, and this targets CD33 on the surface of myeloblasts. So we can use it in AML already in first line as an add-on to chemotherapy. Main side effects of this is that these people can have really high fevers, for example. In BLL, we have a few. There you have the CD20 antibody rituximab, which has been around for quite a long time as an add-on. It can be given IV or subcutaneously, which is nice. And then you have CD19 targeting blinatumomab. This is available in second line. It's a continuous infusion that we give for typically 4 weeks. And then another conjugate, Besponsa, inotuzumab ozogamicin, which targets CD22 and can be given as monotherapy in BALL. Lastly, we have the availability of the CAR T cell therapy. So for relapsed refractory BALL cases, typically below 25, 26 years of age, we can use Kymriah. And CAR T cells are autologous T cells, so from the patient themselves, and they are obtained via apheresis. Subsequently, they are modified in a lab to recognize leukemic blasts. We then condition our patient a bit like we do for a stem cell transplant, but usually less intense. And then we infuse the CAR T cells. And these CAR T cells, when they enter the body of your patient, they will search and destroy the remaining blasts that are still present in your patient. Now, this is relatively new. It works quite well, but it has some serious side effects that you should be aware of. First of all, we have the cytokine release syndrome, or CRS, which can be treated with the use of tocilizumab, and it occurs usually 1 to 10 days after infusion with a median of 3 days. And it looks a bit like your patient is developing a sepsis. They can have fever, sweating, vomiting, diarrhea, but they can also have shortness of breath, or even hemodynamic instability and hypoxia that require transfer to intensive care units. So CAR T cells should only be administered in an experienced center with available ICU beds. We also see some important neurotoxicity for which we can give steroids, and it's typically really an encephalopathy. So your patient can be somnolent, confused, they can have cognitive dysfunction or memory problems, for example. We can also see tumor lysis syndrome in these patients. It also induces cytopenias, which sometimes can last quite a while. And as with chemotherapy, patients can also have febrile neutropenia. We should be treated with the appropriate antibiotics. And now with this, I'm moving towards my conclusion slide. So I believe that we're moving more and more towards a personalized approach of the management of acute leukemias. And this starts with profiling our patients as well as the disease. So when we have a new diagnosis, we need to have a good look at our patient. Age, performance status, comorbidity, it will tell us which treatment this patient will be able to support. But we also profile the disease. We look at it under the microscope to decipher its characteristics, but we also unravel its genetics. And all this information together will tell us something about a specific risk category and prognosis for this patient. It also identifies treatment targets for which we can then choose the appropriate treatment really tailored to one patient, intensive chemotherapy or reduced intensity. Can we add targeted treatment? Can we maybe use a CAR T cell? So this is really tailored to every patient specifically. And then actually, our work doesn't stop there. During the treatment, we really need to keep evaluating the disease. Are we reaching the remission that we are aiming for? And this allows us to tailor the intensity of the treatment. Sometimes we see that we need to increase intensity because we're really not reaching our goals. But sometimes we can also identify patients that may benefit from reduced intensity because the disease is responding well, and this way we can avoid toxicity of our treatment. And it also helps us to decide which patients should move on to allogeneic stem cell transplantation, and to identify the patients where this is actually not necessary at all. So with this, I come to the end of my presentation. I thank you for listening, and I'm happy to take any questions.
Thank you so much, Inga. That was amazing. And you have really helped us to distill some of the really complex information around acute leukemia to make it feel as though we can apply that in our own practice settings. So that's really helpful. So the floor is now open for our first Q&A session, and we have about 10 minutes for this Q&A, so please do keep the questions coming through. I do have a couple of questions already, so I'm just going to ask you those if that's okay, Inga. So my first question is around the role of autologous transplantation in acute leukemia and what your experience and opinion is of autologous transplant in acute leukemia.
Well, we don't do it often anymore. Usually we well, it depends a bit on whether it's a myeloid or a lymphoid leukemia, of course. But for example, in the ALLs, also if you look at the guidelines or the common opinions about this, there is not much room for autologous transplant anymore. So either you go all the way, and then you really need to bring them to an allogeneic stem cell transplantation, or well, you can avoid transplantation all in all. For the myeloid leukemias, we rarely still do it. Basically, for those patients where well, sometimes you have these patients where you're really uneasy to not transplant them, but if you've really struggled to get them through their chemotherapy, okay, so you've reached a remission, but you have, for example, unfavorable genetics where you prefer to go to allo transplant, but sometimes it's just not possible. You know that they will not support it, and for those patients, we sometimes still do it, but it's in our practice, it's become quite rare.
So you're generally using it as an opportunity to just further dose intensify if you're able to do that at the end of treatment.
Yeah.
Thank you, Inga. I have one further question for you, and do keep posting questions through the Q&A section. In referring really to immunotherapy, really, are there any special considerations that you would like to share with the attendees for the session around the use of Mylotarg, and secondly, the use of blinatumomab in the clinical setting?
Yes, so what the Mylotarg, it's quite heavy. So typically we give it in combination. We use the 7+3 regimen, so they get cytarabine and daunorubicin, and this in itself is quite heavy on your patients. Some of them will have very high fevers. They will be really, really ill, and then we throw the Mylotarg on top of that. So it's a bit adding insult to injury there. So what we see is that they can be quite ill from this. So typically the high fevers, it can be managed a bit by like giving steroids before you have the Mylotarg infusion. It's also on the label of Mylotarg that sometimes we can have like bronchospasm. So people can start to have, you can hear wheezing, a bit like an asthma attack. So in patients who are a bit more fragile on the respiratory side, we tend to do this. Or if you just see that after your first infusion, they supported it quite badly, then you can mitigate the side effects by giving them, for example, Solumedrol or Solucortef or something before you give the infusion there. Typically for the other ones, also it's a bit the same for the inotuzumab, because actually it's the same drug conjugate, so the effects are quite similar. For rituximab or the anti-CD20, we have long-standing experience there. It's mainly the infusion-related reactions. So the first time you give it, it should also be a very slow IV, slow increase. But this is probably something that you're already very familiar with, and we're able to manage it quite well. The other option that we have, well, it's typically a bit very specific because it's a schedule with a 4-week IV infusion. I must say that we haven't given it a lot, just also because based on reimbursement criteria, and you need a very specific patient profile. So for now, we haven't had many patients that actually received this drug, though I believe that there are some very good indications. But yeah, we should also, yeah, it's something I haven't had very much experience with myself because I haven't seen many patients, but it's something for example in our center, it's something that we can do in an outpatient setting even. So we have these systems also. Similarly we can do it for antibiotics, and so we have this system approved because it's usually quite well tolerated. Or it's less violent than the other ones. Yeah.
Sure. Thank you. Thinking about Mylotarg and inotuzumab, I guess to a certain extent, when we first started using Mylotarg, gemtuzumab, probably about 15 years ago now in clinical practice, we were seeing occasional incidents of veno-occlusive disease following Mylotarg, and we know that past use of Mylotarg is also a risk factor for veno-occlusive disease at transplant. Could you talk a little bit about some of the things that nurses by the bedside could be looking out for with regards to the development of veno-occlusive disease?
Yes, so it's not only the Minotaur, it's also inotuzumab, so the one that's available for ALL. And this is also something for us that really guides our decision making. Should we give it or should we give something else if we want to bring our patient to transplant, because you're adding the risk of VOD. Now, these patients, well, typically it's quite a difficult diagnosis. Sometimes it can take a while to really know what's going on. You see that there's something going wrong with your patient, but you don't really know what it is. And in our lab results, we typically see the liver function tests that are getting elevated. So of course that's quite an obvious hint. But what you see typically is that they can start to accumulate ascites, so abdominal fluids. So your patient's belly will become inflated, but yeah, it will be mainly fluids accumulating. So if you put them on a scale, that's why you should weigh them at least once a day, and you start to see these rapid increases of weight, and something's going on, which should, and if your patient received, for example, the Mylotarg, then you should be alerted that they have a high risk for this. It's really important to spot it early because, okay, it's very hard to treat, but it has a very high mortality. So the rapid gain weight is something that should really alert you that something's going on. And then they can start to have also typically that they will have a respiratory failure if you don't intervene. So the fluids will start to accumulate a bit everywhere actually, but typically the abdominal distension, discomfort, and then in the end, well, you will have jaundice as well, but this is usually a late sign, of course. And then what we typically do is, well, you should start by performing an ultrasound to look at his liver, what's going on. Do we really have a lot of intra-abdominal fluids? But if you really want your diagnosis, you will have to perform a liver biopsy. So any patient that will start to inflate, for example, you will see that they're very uncomfortable, they will have respiratory problems, and if you then see a rapid weight gain, then it should really like sound the alarm.
Yeah, I mean, we know that liver biopsies in these patients are incredibly risky procedures, and so often veno-occlusive disease can be a diagnosis of exclusion. And if we're treating early on in the disease pathway and the development of the disease, then we will see resolution of symptoms if we start treatment with Defitelio or defibrotide, I guess, in those patients where that's appropriate. It's a hard diagnosis to make without a biopsy, but biopsies are inherently risky in these people. And I have one further question for you, Inga, if that's okay. I know we're grilling you this afternoon. It's a little bit about, in acute leukemia patients, some of the special considerations that we make for the young patients and also for the very old patients, because I know there are some guiding principles around treatments and treatment considerations for those people who are old, and more increasingly because of the indications for reduced intensity condition transplants and the degree to which they are so well tolerated by patients who are otherwise quite frail. Sometimes we're transplanting patients who are quite old, quite elderly, and I'm wondering if there are any special considerations that you make in terms of assessment of those patients in your practice.
Well, in our hospital, we have a system where there's actually a collaboration with the Department of Geriatrics. And then if we have patients which were a bit in doubt, sometimes it's really obvious that they're frail, that they're weak, and there's really not a lot of room for intensive treatment. But sometimes you have these patients where at first glance you think maybe it's possible here, but then you really want to avoid starting your intensive treatment and running into issues that you really hadn't foreseen. So there we have a collaboration with the Department of Geriatrics, and there's this team of geriatric nurses and doctors that really screen these patients, which is quite extensive. Of course, we look at the biology of the patient, what are their comorbidities and so on. But we also look at, for example, their medication. If you have an elderly patient who is on 7, 8, 9 different drugs in maintenance, that's never a good sign. We also perform a cognitive evaluation because sometimes they can have some mild cognitive impairment that's really not evident when you just in regular contact. But well, it might also affect your prognosis. So it's really important. There are established tools for this and screening, but I'm not really a fan of those because of course they it's just like ticking boxes for your patients. And if you really have the geriatrics department involved, if that's possible, they have a nicer feeling for really the fitness of your patient. On the other hand, there have also been studies that we should really be careful to just say, oh, but this patient is old, just will always go for reduced intensity, because there's also a risk of under treating these patients because we're easily judging them to be too frail or too old. So this is a very difficult balance, and I think as doctors, it's our obligation to just at least consider it in every patient. If you have good reasons not to go there, not to go for intensive treatment, then you shouldn't. But we shouldn't be too quick to think that a patient will not be able to support it. On the other hand, I think as nurses, in your daily contact with your patient, I think there's some subtleties that we don't see when we just walk in, we examine them, we talk to them, and then up we move on to the next one. So I think if there are some things that you see, like this patient has some subtle issues with some obvious daily activities, for example, that it's also very interesting to know, even if you've started intensive treatment, well, it can also affect your decision to go to transplant or not, for example. So it's a very different view, but if it's possible to have the assistance of a geriatrics department, I think that's really a useful option. And that we should also really listen to the experience of the nurses with the patient, because it tells us a lot more about how this patient will function in his daily life.
Yeah. Thank you, Inge. I think you highlight, I mean, the biology of the leukemia is often a little bit different in the elderly patient than it is in a younger patient. We know that there's a lot of evidence to suggest that, but what you really highlight is the complexity in approaching these patients and really having a structured approach to be able to do that with the support of specialist teams can help with being able to be open with the patients around the true risks associated with potentially stepping into more intensive treatment when people are chronologically old, if they don't even appear to be biologically very old. So that's great. Thank you so much. That brings our session on our time with you to a closing. Thank you so very much for sharing your experiences with us this afternoon. Thank you.
You're welcome.
So that brings me to invite Eric Ertz, who's a great friend and colleague of mine through the work of EBMT, and we have known each other for a number of years now. Eric is the nurse manager of the stem cell transplant ward and the hematology course at University Hospital in Zurich. In Switzerland. And Eric's real areas of interest focus on hematology, oncology, and stem cell transplant. And in 2005, he developed the very first hematology oncology nursing model in Switzerland, which gives the nurses an opportunity to specialize in hematology and oncology. In addition, he's really interested in the improvement of patient care, and he's responsible for nursing accreditation in Switzerland. Eric's a past president of the European Group of Blood and Marrow Transplant Nurses Group, and he's the current president of the Hematology Nurses and Healthcare Professionals Group, the HNHCP. I'd like to warmly welcome Eric to join us this afternoon, and he's going to give us a real overview and share with us his expertise and experiences of lymphoma. Thank you, Eric.
Well, thank you. I will first try to share my screen. Okay, is it okay?
It's perfect, Eric, thank you.
Thank you. Okay, yeah, thank you very much, Michelle. Thank you very much, Annelie, for your warm welcome, for your introduction, and also to join this very nice meeting. First of all, I don't have any potential conflicts for this presentation. And well, starting with talking about lymphoma, as you know, not only for lymphoma, but also for other diseases, for many patients, survival is a saga of remission and rehabilitation, followed perhaps by re-diagnosis and more treatment. Patients must learn to monitor their health in a new way and learn what is healthy and safe for their new modified lives. Patients need healthcare providers who understand the challenges of long-term survival and do not minimize or dismiss their concerns and symptoms. The key roles of us as healthcare professionals is providing support for patients and families, providing information and education, managing and delivering treatments and supportive therapies, and monitoring patients and treatment effects. So I will talk, of course, about lymphoma. I will highlight the nurses' symptoms and what we can do for our patients. But first of all, what is lymphoma? Lymphoma is the most common hematological malignancy. The two main categories of lymphomas are non-Hodgkin lymphoma and Hodgkin lymphoma, also referred to a Hodgkin disease. Lymphomas are categorized by an uncontrolled production and growth of lymphocytes B or T cells. These cancerous lymphocytes often travel to the lymph nodes, the spleen, the bone marrow, blood, and other organs. Because lymphatic tissue is present in many parts of the body, lymphoma can start almost anywhere. It may develop in a single lymph node, a group of lymph nodes, or in other parts of the lymphatic system, such as the spleen, bone marrow, or other extranodal sites. First, a little bit about Hodgkin lymphoma. Hodgkin lymphoma is an uncommon malignancy. The annual incidence is around 1.2 per 100,000 for males and 0.8 per 100,000 for females worldwide, and between 3 and 4 new cases per 100,000 persons in the Western world. It accounts for less than 1% of all cancers worldwide and for 14% of lymphomas. The highest rates are in the southern part of Europe and the northern part of America. More than 9,000 new cases and more than 1,000 deaths expected in the US in 2013. The peaks we see in Hodgkin lymphomas are when people have the age between 50 and 30 years, and people younger than 50 years. Non-Hodgkin lymphomas is the 10th most common cancer worldwide, with an estimated of 356,000 new cases diagnosed in 2008. It comprises 41% of hematological cancers worldwide. The incidence, well, we have to make a difference between the more developed countries, 10.3 in male patients and 6.6 in female patients. In less developed countries, we see 4.3 in male patients and 2.6 in female patients. The annual rise is between 1 and 4 persons observed between the 70s and the 90s, resulting in almost a doubling of non-Hodgkin incidence, particularly in elderly people, so above 55 years. Well, the diagnosis, how to diagnose lymphoma. There are no screening tests or preventing methods available. It's usually not evident in the blood, so you need to have a detailed medical history. You have to review signs and symptoms of lymphoma. In general, it occurs, you will see in your patients symptoms like fatigue, a generalized illnesses, or local pain. And of course, not to forget, you often see very, very often the B symptoms like weight loss, fever, and night sweating. Well, there are several diagnostic tests and techniques you have to do with your lymphoma patients, first starting with a lymph node biopsy. Then do the several blood tests, as you see here. Then most important, do the several images, like a CT or an MRI scan, and in most cases, you have to do a PET scan. Then a biopsy, a bone marrow aspiration, a lumbar puncture. Then you have to do some molecular analysis, as mentioned here. Well, in most cases, hematologicals are using the Ann Arbor staging for lymphomas. You'll see it here, stage 1 till stage 4. In stage 1, you have the involvement of a single lymph node region. In stage 2, you have the involvement of more than 2 lymph node regions on the same side of the diaphragma. In stage 3, you have the involvement of lymph nodes regions on both sides of the diaphragma. And on stage 4, you have the involvement of 1 or more extra lymphatic sites with or without associated lymph nodes involvement, or isolated extra lymphatic organ involvement with distant nodal involvement. Well, here you see it a little bit better, the stages. You see a scheme for lymphomas. The stage identifies the location of the disease, and it does not reflect how well or how poorly a patient may respond to treatment. Living with lymphoma, well, it's often breaking the bad news. So one of the most challenging events for patients and their families, it's important, we do have important factors from the patient perspective. So healthcare providers have the ability to adapt to their emotional needs, genuinely personalized and empathic approach, having accompanying or also give your information via leaflets. We do see different age groups, and they may react differently to learning about their diagnosis. For elderly patients, cancer is often a synonym of death. For younger patients, you have to be proactive. So from my perspective, it's very important to approach those patients individual. For example, last week we diagnosed a young patient, 18 years old, with Hodgkin lymphoma, and he couldn't believe he has a cancer. So in several sessions, together with our hematologists and nurse specialists, we tried to clarify how ill he was. And then also last week, we had a lady with a non-Hodgkin lymphoma with CNS. And there we did the same clarification together with her husband and her daughter. So in several sessions, we explained her the disease and the treatment plan. So it's very important to take the time. Well, the aims of the lymphoma treatment, you have to differentiate about indolent lymphomas. There sometimes you can watch and wait, and the prolongation of the disease-free period, minimizing disease extent, preventing, of course, symptoms. Then you have the aggressive lymphomas, and there you need to treat patients aggressive to achieve complete or partial remission. Well, and I want to discuss with you the very different types of lymphoma treatment. And of course, it's the treatment, it depends on the type of the lymphoma. For Hodgkin, you have another treatment as a non-Hodgkin lymphoma. And of course, as you saw before, it's depending on the Ann Arbor classification and the location of the lymphoma, but also how quickly the cancer is growing. Is it the indolent or aggressive lymphoma? The patient's age is, of course, important, age adjusted to the International Prognostic Index risk level. Patients, you have to look at the feasibility of the dose-intensified approaches. You have also have a look, is this patient eligible for stem cell transplant, or are there other comorbidities? Well, of course, one important treatment for lymphomas is chemotherapy, commonly used treatment for the non-Hodgkin lymphoma, may be given as a single agent or combination. The treatment is tailored to patients' individual needs. You can use single agent chemotherapies, but very often you are using the common chemotherapy agents like cyclophosphamide, like fludarabine, bendamustine, cyclophosphamide, or chlorambucil. And also the combination of different chemotherapies, and that's important, they will often are associated with more side effects. Well, very often you're also using in the treatment of lymphomas rituximab or other monoclonal antibodies and radioimmunotherapy. Well, another treatment you very often see, for example, for the Hodgkin lymphoma patients, is radiotherapy. A high energy rays damage and destroy lymphoma cells. Typical treatment course of 2 till 6 weeks. So also a very intensive treatment for our patients. A complete regression of lymphopathology can be achieved in patients with localized follicular lymphoma, for example, and the symptoms caused by organ enlargement can be reduced or elevated, maybe also used in combination with chemotherapy. Then, of course, we often can treat patients with some kind of a stem cell transplantation, usually reserved for patients with a relapsed non-Hodgkin lymphoma. Well, there you have to give your patients a high-dose chemotherapy with or without radiation to deplete all the cells from the bone marrow. Stem cells collected either from the bone marrow or from the peripheral blood stem cell collection using apheresis or the cell separator. As you know, the two main types of stem cell transplant depending on the source of the stem cells. So you can go for an auto transplant or for an allogenic transplant. The infusion of stem cells allows bone marrow to recover from chemotherapy and supply new healthy blood cells. Well, the previous speaker talked already about a new therapy. So what is new about the CAR T therapy? It's the chimeric antigen receptor T-cell therapy program. And the development of this CAR T therapy has regulated demands and unique operational processes that vary across settings. The infrastructure in which CAR T-cell therapy is implemented has implications for nursing education and competencies. So here I made an overview of the production process of the CAR T cells. Well, I think the most important things for us as nurses are if you together with the hematologists can have a look, well, is your patient with a lymphoma, with a non-Hodgkin lymphoma, is he eligible? So you do have an eligibility evaluation. Then if so, you have to do a leukapheresis, mostly in your outpatient setting. Then if the disease, the non-Hodgkin lymphoma, for example, isn't under control, you have to bridge, you have to offer your patient a bridging therapy. Then starting the process, if you have received your CAR T cells in your hospital, we start with a lymphodepleting chemotherapy, then do the CAR T cell infusion, and there we as nurses have a very important role to monitor and also to do in an outpatient setting the long-term follow-up for about 15 years. Well, we started in our setting in 2018 with the first CAR T cell infusion. And first, of course, it was very spectacular. And now we are doing about 20 CAR T cell therapies a year in our setting. And nowadays, well, of course, depending on the patient situation, we often say as a very well educated team, well, it's unspectacular. So here at the bottom, you see very simple explained again the process of the CAR T cell therapy. Well, as I mentioned before, after the CAR T cell infusion, we as nurses have an important role. Of course, also before the CAR T cell process, because in our setting, for example, we are seeing all our patients before they enter the ward to discuss the whole therapy plan with patients and their loved ones. Well, after the CAR T cell infusions, again, we have a very important role. And as the previous speaker already mentioned, we have to do there a very proper assessment and management of acute toxicities, like, for example, as here you see on this slide, the cytokine release syndrome. It's a group of symptoms associated with the use of immunotherapy. CRS results from the release of substance called cytokines, it are proteins, into the blood circulation. These cytokines cause inflammation. CRS can affect many different parts of the body and at minimum resemble flu-like symptoms. The most common observed side effects are high fever, low blood pressure, a high heart rate, fatigue, hypoxia, and organ failures. In approximately between 10 and 25% of the patients, CRS resulted in severe or life-threatening symptoms requiring life support. So often they need then an intensive care unit. They need blood pressure medications, sometimes dialysis or ventilators. So here we have a very important role, and also here you need to have a very good and intensive collaboration with your intensive care unit. Well, as a group, I think the field is still learning about CAR T-cell therapy. Again, how not only to predict toxicity, but which of these products could be the best, as well as which platform may be optional. And I hope that in the future, as we continue with some of the currently ongoing trials presented, we are going to learn how to use these drugs more safely and reach higher efficacy rate across patients with several different aggressive cancers. So there is a lot of hope. There is a hype at this moment about the CAR T-cell therapies, but well, sometimes you have to be honest to your patients and say also this therapy might not work. Another sometimes underestimated topic is palliative treatment and care. So in our setting, for example, we are consulting then our palliative care treatment team to enhance quality of life, to relieve them from pain, and it may also positively influence the course of illnesses. So a multidisciplinary approach there is very important. As I mentioned before, when we treat patients with lymphomas, there are more than 80, by the way, there are more than 80 different types of lymphoma. And there we have an important role as nurses to have a look at the different side effects from the lymphoma treatment. In the diagnostic phase, in the treatment phase, but also in the post-treatment long-term follow-up phase. And the main goal, of course, is to prevent complications during each phase. I here want to mention some important, well, sometimes also underestimated symptoms like fatigue. There you have to differentiate, okay, has this patient maybe an anemia? So there, of course, the patient needs blood transfusion, or he needs another drug therapy. And the practical tips where you can support your patients is to eat healthy, to eat a well-balanced diet, to do regular gentle exercises. So also there in our daily practice, we are collaborating intensively with our physiotherapist team, but also to have an adequate rest, to avoid caffeine just before bedtime. Well, how do we assess in our patients the severity of fatigue? So very easy, we use a thermometer. No fatigue is 0, and a severe fatigue is 9. And here, in our multidisciplinary setting, we always have on Thursday our meetings. We discuss with the multidisciplinary team, so here mostly together with our nutrition specialists and with our physiotherapists, how can we support the patients with severe fatigue. Then in Hodgkin, but also but mainly in non-Hodgkin lymphoma patients, those patients suffer often about pain. So here you should know the WH three-step energetic ladder. And to summarize this, on the one side, you have to offer early on time your patients the right to proper pain, the drug medications, but also together with your multidisciplinary team, you can offer patients, for example, TENS therapy or massage or acupuncture, or involve the psychological support for those patients. Well, another often complication we'd see after chemotherapy or after radiotherapy is managing the sore throat or mouth, so the oral mucositis. Also here is important to offer your patients adequate pain management on time. So we are starting very early with the PCA pump with morphine. Here you see on the right side some practical tips for your patients. For example, I will highlight a few. So we are only using filtered water to rinse them out from the patients. So we don't use any other products. We did a study about that. And well, we are now also looking on the oral cryotherapy, and we hope to start with the study if it really works well, if it has an influence on oral mucositis. We will start soon a study about it if it's really evident to start oral cryotherapy in those patients. Another side effect can be peripheral neuropathy. Also here, it's important to start early enough pain medication, but also we here involve early enough our physiotherapist team, and sometimes they help patients with acupuncture or with some exercises. Well, then it's important, of course, to offer your patients supportive treatment and care. So from the medical side, to offer early enough, of course, drugs like antiemetics, like analgesics, like steroids, like transfusions, like GCSF, etc. But here we have also a role to advise the patients and their loved ones with information, help them with the emotional and physical and practical aspects, and also to involve in some patient situations a social work to talk about financial and their social needs. And also we link here, especially in Hodgkin and non-Hodgkin lymphoma patients, we link them here with one of the patient support groups. Well, again, our role of nurses is to support patients in their process, and also their caregivers to educate them properly, because it helps patients to cope with lymphoma, including its complications and the impact on the quality of life. Education begins before treatment starts and continues to long-term care. It should include advice about reliable versus unreliable sources of information. And we as nurses can also help facilitate discussion with the physician about the patient's illness and the treatment plans. So only, in my opinion, only together And here I showed you some very important members of our treatment team. In conclusion, the management of patients with lymphoma is complicated by the relapsing of the disease and its associated psychological impact. We as nurses play a critical role during diagnosis and the several stages of the disease, when they can provide much needed patient support and education. We as nurses need to work closely with the multidisciplinary team. Nurses and other healthcare professionals need to be provided with appropriate education. So to start with education, that's in my opinion, the first step. And that's why we, as Hematological Nurses and Healthcare Professionals Group, HNHCP, we developed a lymphoma learning program. So within a few days, on the 1st of June, we will launch a new lymphoma learning program, which is broken down into 5 modules. Module 1 is about understanding the adult lymphomas. Module 2, we will highlight the Hodgkin lymphomas. In module 3, the non-Hodgkin lymphomas. In module 4, we will discuss the comprehensive management of the adult patients with lymphomas. And in module 5, we will discuss the management of lymphomas in special clinical situations, like pregnancy, etc. So it's a 84 A4 sites textbook, together linked with the e-learning program, available again from the 1st of June at our website, www.hemcare.org. So you can always send me an email, and now I will be ready for your questions. Thank you very much.
Thank you so much, Eric. That was great, and a real comprehensive overview of where we are at with the care of lymphoma patients and the whole range of treatments. Unfortunately, we're going to be too tight, I think, to have many questions at the end of this session. Thank you for introducing, though, your upcoming module for lymphoma, because I think that will truly be a great educational resource for people who want to either improve their skills in lymphoma, or who are starting from scratch and want to have the foundations of education and training in looking after patients with lymphoma. So thank you so much for sharing that exciting resource with us this afternoon. I'm afraid we're because of time, we won't have time for any questions. Eric, I'm sorry. Please do stay online if there are any questions that are posted in the chat during this session. Then we'll be able to answer those in the panelist view on the chat. So thank you for now, Eric. Thank you. I now move to our next speaker, who has pre-recorded their session, so we won't have time for have the opportunity for a live question and answer session after this session. But if you do have any questions around lymphoma, Eric will stay online and we will try to answer those questions as we move through. So now we welcome Maaike de Ruiter, who will present for us her talk on multiple myeloma. She's working as a nurse practitioner in the hematology department at Amsterdam University Medical Center, and she's also the European Blood and Marrow Transplant Society's chronic malignancy working party nurse, and has made a huge contribution to the working of that working party, to the work of that working party. In her clinical care, she's focused on patients who are being admitted for high-dose chemotherapy and autologous or allogeneic stem cell transplantation. And she also has a function in the outpatient ward, working with patients who have multiple myeloma and lymphoma, providing care for them and support for them in their pre and post-transplant time. So without further ado, we will start the presentation for Amika, and I do hope you all enjoy this. Thank you.
Hello everyone, welcome to my presentation about multiple myeloma. First, I want to thank the Saudi Society of Blood and Marrow Transplantation for inviting me to give this presentation. I'm Maaike de Ruiter. I'm working as a nurse practitioner at Amsterdam UMC location VUMC. I'm working at the Hematology ward where I see patients who are admitted and also see patients at the outpatient ward with receiving high dose chemotherapy and autologous stem cell transplantation. I'm also one of the EBMT CMWP nurses, and that stands for the Chronic Malignancy Working Party. First, to start with some basic information about multiple myeloma. Multiple myeloma accounts for about 10% of the hematological malignancy. It's a cancer of plasma cells, and where normal plasma cells are found in the bone marrow, and they are a very important part of our immune system. When B cells respond to an infection, they mature and change into plasma cells. In general, when plasma cells become cancerous and go out of control, this is called multiple myeloma. The plasma cells make an abnormal protein, also called antibody, known by several different names, including monoclonal immunoglobulin, monoclonal protein, M protein, M spike, or paraprotein. So here you see that the plasma cells produced an abnormal antibody production. I think we all have heard about the CREB criteria. The acronym CREB summarizes the most typical clinical manifestations, short of calcium elevation, renal failure, anemia, and bone disease. So how does these signs appear? The myeloma cells make a substance that tells the osteoclast to speed up dissolving the bones. So old bones are broken down without any new bone to replace it. And that makes the bones very weak and easy to break. And that is what's causing our patients a lot of pain. And fractured bones are a major problem in people with myeloma. This increase of bone breaking down can also raise calcium levels in the blood. And the overgrowth of plasma cells in the bone marrow can crowd out normal blood-forming cells, and that could lead to anemia. And myeloma cells make an antibody that can damage the kidneys, and that can cause kidney failure. If you look at treatment options, there are a lot of options. It could be the most challenging part of treating patients with multiple myeloma. It's finding the cure that fits your patient's disease and fits your patients best. In this presentation, I will tell you more about the new treatment options for patients with refractory multiple myeloma and the toxicity that could be a cure. But I'm starting with new treatment options for newly diagnosed multiple myeloma patients. Over the last years, there's an increase of therapy options for patients with multiple myeloma. On this slide, you see the option in 1984. we could choose between melphalan, vincristine, adiamycine, and of course there was also dexamethasone and prednisolone. And then now in 2021, we have a lot of options, especially for a patient in the second line of therapy. Of course, there are guidelines you can follow to choose what's the best treatment there is for your patients. Age, comorbidities, and cytogenetics are taken along in the risk factors of multiple myeloma, and that helps you to decide which treatment to start. But it's also very important to know if the patient is classified to fit or unfit. A tool what can help is the frailty score. The International Myeloma Working Group has developed an index to identify frail patients who might have a worse overall survival and progression-free survival, an increased incidence of non-hematological toxicity, and discontinuation rate. The score is based on age, on the Charlson Comorbidity Index, on the CAT activity of daily living, and the instrumental ADL. On this slide, you see the outcomes of a study performed by Palumbo et al. In 2015. And you can see here that frailty can predict survival better than age and chromosomal abnormalities. What also can help making the decision how to treat the patient is the cytogenetics. Certain chromosomes changes can mean a poor outcome. For example, the deletion 17p. Another genetic abnormality that predicts a poor outcome is an exchange of material from chromosome 4 and 14 and 14 and 16, and it's called a translocation. And sometimes patient has also a deletion 17p and translocation for 14, and that is called double hit multiple myeloma. And of course, we also have a triple hit multiple myeloma, which refers to the presence of 3 or more high-risk abnormalities. So why is that so important to know? Studies have been shown that patients with high-risk multiple myeloma of high-risk cytogenetics have better outcomes after tender transplantation. And that should be a tender transplantation in the first line of therapy. And that means that when patients receive the first high-dose melphalan and autologous stem cell transplantation, 3 months later, they receive another high-dose melphalan and autologous stem cell transplantation. It's here you see that the progression-free survival goes from 26.7 to 46 months. Some slide before, I told you about new treatment options. A lot of possibilities in the refractory myeloma group. And when we talk about the newly diagnosed multiple myeloma patients, we talk about daratumumab. Daratumumab is a monoclonal antibody that is designed to attack a specific target. With daratumumab, the target is CD38. And here you see it on the slide that it's on the plasma cell, on the surface of the myeloma cells. A few years ago, the great positive effects of DARA were published in patients with relapse of multiple myeloma, and therefore daratumumab was moved forward to the first line of therapy. The addition of daratumumab to the standard care of treatment is now being investigated in several studies. Here you see the Griffin trial. It started in 2016 until 2018, in which daratumumab was added to the regime RVD. And RVD is for Revlimid, bortezomib, and dexamethasone. Patients received 4 cycles of RVD, then received autologous high-dose melphalan and autologous stem cell transplantation, then consolidation therapy with 2 cycles of RVD, and then maintenance treatment with lenalidomide. And in the study, on the study arm, the patient received the standard arm of care and daratumumab. So here you see the responses at different time points during the study when treated with DAR-RVD versus RVD. In both study arms, responses improved over time. Everything in green, blue, orange, and purple means response, but orange and purple means complete remission. So no tumor protein could be found anymore. If you look, more patients in the DAR-RVD had such a good response overall over all the time points as compared to the RVD without DARA, meaning that adding DARA improved deepened responses. There are some specific toxicity you need to be aware of when you treat patients with daratumumab. There could be some severe infusion reaction, including anaphylactic reactions. So in the first infusion, you need to check your patients very well. Patient could show signs of hypoxia, dyspnea, hypertension, and it could be showing you in cough, of chills or vomiting. So patient do get some pre-medication with antihistamines and corticosteroids, and sometimes it's necessary to, when the patient has a severe reaction, to stop the infusion and restart later with, and before that, giving your patients some other medications. So you need to take a close look at your patients when they receive this treatment, especially the first times. New therapy options for patients with relapsed multiple myeloma are these new forms of immunotherapies. I think we have all heard about the CAR T-cell therapies. On this slide, bispecific antibodies is mentioned. It's a form of therapy that connects and brings the T-cell to specific target points on the plasma cells. For now, time is too short to tell you more about this new, very promising therapy. So just telling you about all these new kinds of therapies that are possible to give to your patients. Is there still a role for high-dose melphalan and autologous stem cell transplantation? Yes, there is. A review of the EBMT Chronic Malignancy Working Party, published by Laum Cardet et al. In May 2020, showed us that it is still the standard of care for newly diagnosed transplant-eligible patients. It also shows us that age is less important than general fitness. That renal impairment is not a contraindication. And also that tandem transplantation should be considered with patients with cytogenetically high risk features, especially when patients have deletions FTP. So here on this slide, you see an overview of the transplantation in patients with multiple myeloma registered by the EBMT. You still there is very, it is still getting very high. So it's still very useful treatment. So we are aware of all the toxicity that could appear during treatment. For nurses, it is important to see if there are any signs and early signs of toxicity, and talk about it with the physician or the nurse practitioner, so we can make the balance between toxicity and efficiency, because that's what makes the best survival. We treat toxicity with dose adjustments, and also with follow-up of the toxicity, and give supportive care. And especially on the patient with multiple myeloma, they receive more and more long terms of therapy. So it's very important to follow up the toxicity signs. There are some specific toxicity that we see at patients with multiple myeloma during treatment, but also before starting treatments, or in the periods when they don't receive any treatment. I will tell you more about diarrhea, thrombosis, polyneuropathy, and infections. Diarrhea could appear in patients using lenalidomide, not only at the start, but also when they already received for several months lenalidomide, also after 70 until 23 months. It is caused by bile exit malabsorption, and you can prescribe Creston to your patients. Diarrhea could also see with patients treated with bortezomib, and sometimes it is necessary to stop the treatment, to give it a little break and then restart it again, and sometimes you need to do a dose adjustment. But it could also be a side of a viral infection or something else, so you also need to check that. Thrombosis, we see it's when the patient is getting diagnosed with multiple myeloma, but this also could be linked to comorbidities leading to inactivity, but we see it also during treatment, especially during treatment with IMiDs and combined with dexamethasone. Patients needs to have thromboprophylaxis when you start it. But about 5 until 8% of the patients still develop a thrombosis despite the prophylaxis. Of course, there are some signs you can check on your patients when you have a swollen arm, swollen leg, some difference in colors of the skin, could be a little bit red, it could be feeling warmer. So if there are any signs of that, you need to check if there is some signs of thrombosis. Patients could also be complaining about shortness of breath or pain in the chest, combined with a rapid pulse and dizziness, and then you need to check out if there is any signs of pulmonary embolism. And then one of the toxicity, it has a high influence on the quality of life of the patients. Polyneuropathy, it could be disease related. It could also be therapy related. We have several kinds of forms of neuropathy. We have sensory neuropathy, pain or motor neuropathy, and autonomic damage. We can follow up the polyneuropathy by using the common toxicity criteria score. And when patients receive treatment, you need to check that every few weeks, and on some medication every time the patients are receiving bortezomib. Sometimes it's necessary to adjust the dosage or the frequency of the medications. So when patients, there was a study about carfilzomib versus bortezomib, looking at the specific toxicity of neuropathy. And here you see in a study that 6% of the patients who received carfilzomib get neuropathy, and 32 patients using bortezomib gets neuropathy. So that's a big difference. But the carfilzomib has also some specific toxicity. Frequent heart failure has been seen, hypertension, and renal failure. So as a nurse, you need to measure the weight and the blood pressure. So the neuropathy you need to check out, but also some other specific toxicity. I remember last week I talked to a patient who was calling me to ask for a new prescription for some sleeping medication. And I asked her, so you need a new prescriptions, but can you tell me why you cannot sleep? And she told me she had a lot of pain in her hands and the feet that is keeping her awake. And she did receive bortezomib and thalidomide. So it wasn't that she couldn't sleep, but it was that she had a lot of polyneuropathy that was keeping her awake. So I started some medication for the polyneuropathy, and for 2 weeks later I talked to her again, and she told me that she was sleeping great and she didn't have almost any pain anymore, and it was only a low dose of medication. So it shows me again that it's very important to know your patient and to ask why do they have any symptoms, and why they cannot sleep, or why are they complaining about pain, on what moments, so you can help them in the best way possible. Another toxicity that we see a lot of treating patients of multiple myeloma are infection. Infections is caused by the disease because of the plasma cells. When they are very healthy, they can fight infection by making antibody that recognize and attack germs. So a patient with multiple myeloma, the overproduction of monoclonal components consisting of dysfunctional immunoglobulin. So the body isn't capable enough to fight to an infection because they are missing the healthy plasma cells. And during treatments of multiple myeloma, there also could appear neutropenia, and that could give you a high risk of getting an infection. So there are several kinds of infections. We see some viral infection, bacterial infections, and especially when patients are receiving long periods of treatments and long periods of corticosteroids, there's an infections. And that is why we treat patients with antibiotics prophylaxis. So when your patient is calling with a fever, you need to check if there is any signs of this kind of infections, and you need to start treating it early. How can we as nurses support patients with multiple myeloma at other side effects or disease-related toxicity? You need to check if your patient is having any pain due to frail bones or due to neuropathy. We need to know what are the specific drugs toxicity that could be occurred to the patients that we see at our hematology wards. So we can ask if they are having any signs of this specific toxicity, so we can treat it in an early phase. We can identify developing symptom patterns, and also we can monitoring therapy adherence. And that is important because more treatment with multiple myeloma is about oral chemotherapy. And patients need to take the medicines for a very long time. So that could be very hard to take them every time, or to know on what time they need to take the medications. And we also should be looking for care for the caregivers. The treatment of multiple myeloma is becoming more lifelong treatment with less periods without treatment. So it's becoming more a chronic disease. What we can do is, as nurses, support patients in persist treatments in the best way possible. I already talked about neuropathy, and I will mention it again, that it's very important to check if there are any signs of neuropathy, because it has a high influence on the quality of life of patients, not only during treatment, but it could also appear after the treatment is finished. And then we need to see if we can help patients with medication or with some other kind of forms of therapy to support them in treating neuropathy. And it's also important to know the patient. Is it important for the patient to be at home and get treatment? Or do they feel safer in receiving treatment in the hospital? Talk about what patients need and talk about the fears they have. So not only the best therapy for multiple myeloma is important, but what's best for your patient. With this, I want to end, and I want to thank you again for the invitation and the opportunity to tell you more about the very important role of nurses and nurse practitioners during the care of multiple myeloma patients. I wish you a wonderful day, and I hope to see you again. Bye.
I'd like to say a huge thanks to all of our speakers who have presented on such a range of topics in this session. And we will now move to a prayer break, and we are scheduled to restart the programme at 4:05. Thank you.
So good afternoon, everyone. Good afternoon, good morning, good evening. Here in Saudi Arabia, outside Saudi Arabia. So before anything else, I would like to thank the Saudi Society of Blood and Marrow Transplantation for being a part of this 8th annual Saudi Hematology Oncology Nurses Conference in the nursing perspective. So if I may allow you, I am Jennifer Bakal from INPAD Specialist Hospital Daman. And prior to my role as a clinical nurse coordinator, I was an apheresis nurse for 8 years. And this opened up for me as an opportunity. It's like a door behind my back that was open. So as of the moment, I am on my 6th year as a clinical nurse coordinator in adult lymphoma, bone marrow transplant. Now, it's my pleasure to introduce our first speaker. Her name is Miss Laura Borg. She graduated with Bachelor of Science in Adult Nursing from the City University. She also completed as a postgraduate diploma in Oncology and Palliative Care. She was a hematology clinical nurse specialist in Epsom and St. Helier University Hospital National Health Service Trust from 2016 to 2017. Currently, Ms. Borg is working as a leukemia clinical nurse specialist in Royal Marsden Hospital in UK. She acts as an advocate of leukemia patients and their families through providing high-quality patient care. Ms. Laura?
Hello, sorry, I don't know what happened there. The connection went off. I'm just going to share my screen. So thank you very much for the introduction. I'm going to talk to you all about chronic myeloid leukemia, and just a very quick revision and overview about chronic myeloid leukemia. So as we know, it's a myeloproliferative disorder that originates in the stem cell. CML has 3 different phases, the chronic phase, the accelerated phase, and the blast phase. I'll talk a little bit more about these later on. CML is a very rare disorder, and according to Cancer Research UK, there's approximately 790 people that are diagnosed with CML in the UK. This is very small in comparison to acute myeloid leukemia, which is approximately 2,400 per year in the UK. So CML can be diagnosed at any age. It is more common in the older adult, though. So CML patients do have a specific chromosomal translocation of chromosome 9 and 22. So this means swapping parts of the chromosome. So you have chromosome 9, which is also known as the ABL, and chromosome 22, which is known as BCR. And it joins together and it transforms into BCR ABL, which is also known as the Philadelphia chromosome. So this is what we call a fusion gene. And so this fusion gene causes the leukemic cells to make this protein enzyme called tyrosine kinase. So this helps the leukemic cells grow and multiply. So approximately around 95% of cases, of CML cases, do have a BCR-ABL1 gene. So it's one of the very many genetic mutations that can be identified at diagnosis on blood or bone marrow. It's also significant in the monitoring to the response of treatment. So BCR-ABL activates various signaling pathways. It activates tyrosine kinase protein, which encourages the leukemic cells to grow and to multiply. So as I mentioned earlier, CML typically progresses through 3 distinct phases. So, and this all depends on the bone marrow and the blood blast count. So we have a chronic phase. Normally, patients within the chronic phase tend to have blasts of up to 10% in the blood or the bone marrow. Patients in this phase tend to have symptoms that are very easily managed. So fatigue, weight loss, left upper quadrant pain or discomfort, splenomegaly, and night sweats. Normally tends to be picked up very incidentally with a blood test, and it shows abnormal high white count white cells. And if patients are left untreated in the chronic phase, it will develop into the next phases. So the next phase is accelerated phase. So this is normally when we see blasts of up to 20% in the blood and the bone marrow as well. This is where normally you can detect the Philadelphia chromosome as well as new chromosome changes. And patients tend to be a little bit more symptomatic in this phase. So they present with fever, poor appetite, weight loss, fatigue. And also you have the abnormal counts. Then we move on to blast crisis or blast phase. And this is where you have blood or blasts in the blood or the bone marrow anywhere between 20 to 30%. Normally, patients in this phase, well, CML in this phase tends to act more like an acute leukemia. So patients are more symptomatic with infection, bleeding, bone pain, shortness of breath, fatigue. They do tend to have extramedullary blast proliferation as well. This is not included in the spleen. And also the CML cells in this phase do have new chromosome abnormalities as well as the Philadelphia chromosome. So treating CML, there are various different types of treatment. We'll start off with leukapheresis. So this can be undertaken if the high counts are causing signs of hyperviscosity. However, there is an argument that cytoreductive chemotherapy, well, treatment should be started alongside this. Then we have hydroxyurea. So this is also used to reduce the white cell count very rapidly. Hydroxyurea should always be started once bone marrow biopsy has been performed. It also can help with managing symptoms of hyperviscosity, so reducing the white cell count, reducing the spleen size and any of the symptoms. So normally within this treatment, you'd be monitoring for tumor lysis, you'd start prophylactic or treatment tumor lysis medication. But once the CML diagnosis has been done, then TKI treatment should be initiated and the hydroxyurea should be stopped. So then moving on to TKIs, so tyrosine kinase inhibitors. So this is a form of a targeted therapy. So TKI normally targets the abnormal BCR-ABL protein that causes the uncontrolled CML cell growth. So it basically blocks its function, which causes the CML cells to die. Before the treatment of TKIs, imatinib being the first developed in the 1990s, the median survival of anyone who was diagnosed with CML was approximately 3 to 5 years. And the treatment options were palliative care or a stem cell transplant. Nowadays, it's expected that most of CML patients will have a good quality of life and a near to normal life expectancy. The gold standard for treating a newly diagnosed CML is to start a TKI. Imatinib still remains the most popular TKI for choice. for the initial treatment. This is probably due to the extensive experience using this drug. So we have over 15 years of using this drug, and since then there have been no severe or unexpected side effects that have been seen. But although imatinib works very well for most patients, there are some patients who do not have a good response to imatinib, or their response doesn't last that long, or patients do not tolerate the side effects. And for this reason, other similar TKIs have been developed, and these are referred to as second generation and third generation TKIs. So in the UK, dasatinib and nilotinib are licensed for the use in treating a newly diagnosed CML patient, or failed response or not tolerated another TKI. Bosutinib, however, has been licensed when previously treated with one or more TKIs, or for whom imatinib, nilotinib, or dasatinib are not appropriate treatment options. Usually within 3 to 6 months of monitoring the patient's symptoms and their BCR-ABL gene, it kind of becomes clear whether the TKI is going to be successful or not. In the case of resistance or intolerance to the second-line treatments, there's a third-generation drug called ponatinib that's available. In the UK, ponatinib is also approved to treat patients who have T315I mutation, which we know is resistant to imatinib, dasatinib, bosutinib, and nilotinib. Chemotherapy is, so this is generally used in patients who present in the blast phase, and depending on whether it's presenting as a lymphoid or a myeloid acute leukemia, the patients will be treated with chemotherapy and a TKI. So in the UK, we would use FLAG-IDA and a TKI if it was a myeloid, and we would use the UCAR protocol and a TKI if it was a lymphoid. And then stem cell transplant. So allogeneic stem cell transplant is also recommended for the majority of transplant eligible patients who are in the accelerated phase. There are some studies that have confirmed that outcomes are much better following a transplant in comparison to continuing ongoing TKI therapy. However, there is an exception, and this is when patients who present in the accelerated phase, who achieve an optimal cytogenetic and molecular response, but the risk versus benefit does not favor transplant. So this is, for example, an elderly over 70 patient who has multiple comorbidities. So allogeneic stem cell transplants are normally, patients who present in the accelerated and blast phase will definitely have an allogeneic stem cell transplant. There is also patients who are in the chronic phase who progress through multiple lines of TKIs should have an allo reserved as a backup. And relapse post TKI, post allograft should be managed with a TKI and DLI infusions. So this is a rough guide that was created by the NCCN clinical practice, just to show a guide of changing TKI treatments. And basically you look at the length of treatment of the TKI versus the percentage of the BCR-ABL on the international score. Then we move on to the response for treatment. So this is also another guide that's come up and has been developed. And what we're looking for is 3 responses. So we've got the partial cytogenetic response, which should happen within 3 months of starting the TKI. Complete cytogenetic response, which should happen by 6 months. And a major molecular response, which should be achieved by 12 months of starting the TKI. Side effects of treatment. So these are the generic side effects of all the treatment for a CML. And what we're looking at is intolerance. So the intolerance to TKIs can be defined as a combination of non-hematological toxicities of any grade that persist despite optimal supportive measures. So we're trying to reduce the hematological toxicity because cytopenias could also here reflect the anti-leukemic effect of the TKI in the setting of a limited reserve of normal hematopoiesis, rather than a direct toxicity against hematopoietic cells. Then we've got the TKI specific side effects. So the major side effects is cardiac toxicities that we know patients with a history of cardiac disease or peripheral vascular disease should be monitored very closely throughout their TKI treatment. The new BSH guidelines also say that cardiac function should be carried out before treatment starts. It is very rare, but there are some patients who were treated with TKIs who developed serious cardiac events, including congestive heart failure and a QT prolongation. So I just wanted to finish off this presentation with a very interesting and challenging case of a young patient who was diagnosed with CML. And obviously, to maintain confidentiality, we have changed his name. And just to give you a summary, John Doe was 19 years old when he was diagnosed. He presented in A&E reporting left upper quadrant pain. He did have a blood test done, and his blood count showed an HB of 122, white cell count of 155, platelets of 85, basophils of 2, eosinophils of 0.6. He also had a BCR-ABL, which was detected on peripheral blood. So he started off with first-line imatinib. However, he did progress through multiple lines of TKI treatment, then progressed to a lymphoid blast crisis of CML. He was treated with chemotherapy on UCAL14 off trial and ponatinib, followed by a matched unrelated stem cell transplant. So there were multiple factors that affected his treatment and needed to be managed very carefully throughout all of his treatment. He did have a very complex social background, had poor social support. He did attend most of his clinic appointments on his own, had a lot of psychological issues that were mostly related to the anxiety of him attending hospital appointments, the diagnosis, and also dealing with the treatment as well. He showed signs of self-destructive behavior. He used to drink excessive amounts of alcohol most weekends, and also his intake and frequency used to increase leading up to hospital appointments. This was his way of dealing with his anxiety. We worked very closely with psychological support throughout his treatment. But there were a few questions that came up from this, and one of them was adherence and compliance. So he was very open and honest with us, and he did tell us when he missed out doses, and but it's building up the trust with the patient, because adherence and compliance is very important during TKI treatment. The other question which remains unanswered was whether the excessive amount of alcohol he used to drink changed the efficacy of the TKI, therefore him progressing through multiple lines of TKI treatment. He still remains in remission. He's 20 months post-transplant and still remains on a TKI. And the reason I wanted to discuss this case was just to show the difficulty of treating a patient who has been diagnosed with CML. and also to stress the importance of a holistic approach to patient care. It's not just about taking a tablet every day for the rest of their lives. I guess as nurses, we should be making sure the patient has the support to maintain the compliance to hopefully prolong their life expectancy. So thank you very much for listening. Do let me know if you've got any questions.
Oh, thank you, Miss. Sorry for that. Okay, thank you, Miss Laura, for that wonderful and very interesting topic. So, as I can see, there's no question. So I have these two questions for you.
Yeah.
What is the survival rate of CML in your hospital regarding the stem cell transplant allogeneic?
So post stem cell transplant, if they survive past the 1 year post transplant, then obviously their life expectancy does become much better. I don't have a number, but there's very few patients who do end up going into transplant, and the majority of patients we have are living a near to normal life. The majority are over 65, so obviously their life expectancy would be very different in comparison to a 19-year-old. I'm really sorry, I can't hear the question, sorry. I'm so sorry, I can't hear any.
Yeah. Miss Laura, can you hear me now?
Yes, I can hear you now. Thank you.
Okay. So thank you for the response for the first question. Now my second question is regarding the COVID pandemic era. As of the moment, globally we are experiencing that. So how are you handling your CML patients or other hematology patients to this period? Are you stopping, or how they are? What is the how they are receiving their? Are they receiving their vaccination and treatment?
Yes, so we're promoting a lot of patients because most of our CML patients have all been shielding throughout the pandemic. So once the vaccinations were available, we did make sure that most of our patients were vaccinated. Most of our CML patients continued on their TKI treatment with no problems, but I guess the whole thing of everything becoming virtual with the COVID pandemic kind of hit the CML patients quite a lot, because the majority of patients are seen every 3 monthly. So they used to have blood tests remotely, and then we do video consultations with them. So I guess they've kind of avoided coming into hospital as much as possible, but still carried on with their treatment.
Okay, so that's it. So still in our Q&A, there's no additional question, but if in case that there will be a top question later on, we can just stay online, Miss Laura.
Okay.
So yeah, thank you so much for that interesting topic.
Thank you very much and have a lovely day.
Yeah, thank you as well. So for the second speaker, I'll be presenting Mr. Simon Slade. He will be talking about the aplastic anemia. He's currently the clinical nurse specialist at King's College Hospital as an aplastic anemia and bone marrow failure specialist. So prior to this role, he worked as a bone marrow transplant coordinator and having a total of 7 experience in hematology services and in King's College Hospital as well. He is currently the nurse representative for the severe aplastic anemia working party for the EBMT. May I welcome Mr. Simon Slade for the aplastic anemia.
Simon, we can't hear you.
Mr. Simon?
Hello, can you hear me now?
Yes, we can.
Oh, I do apologize. Sorry. I'm so
share your
sorry.
slides, please.
Yes. Again, my name is Simon. Thank you for the introduction, Jennifer. I currently work as the aplastic anemia and bone marrow failure clinical nurse specialist at King's College Hospital. I'm just going to share my slides now, and hopefully you will be able to see them. Give me 1 second. Can you see my slides?
Not yet.
Oh, gosh. Share. Sorry, 1 second.
Okay.
Hopefully now you can see my slides.
Yeah, I can. Yeah, we can see your slides, but can you maximize it? Yeah, okay, now that's perfect.
Thank you. Okay. Sorry for that, guys. Yes, so I'm going to talk to you about aplastic anemia. And just to start, I don't have any disclosures. And just to sort of run through the session aims, briefly going to talk about what happens in the bone marrow. We'll do some definitions of aplastic anemia and some of the workup tests we do at the diagnostic stage. We're going to talk also about some of the differences between an immune-mediated bone marrow failure versus a constitutional genetic or sort of familial aplastic anemia. And these are really important when you're looking at personalized care because the treatment options will be quite different, but we're going to go into that as we go through the session. We'll talk about treatment options, and mainly in the form of, for the more severe and very severe aplastic anemia population. So we'll talk about ATG, which is a horse-derived antibody treatment. It's an immunosuppression. We'll talk about stem cell transplant and some considerations for the aplastic anemia population, sort of getting ready for transplant. And of course, talk about the question of upfront unrelated donor transplants in the adult aplastic anemia population. and then we'll draw some conclusions. And of course, I'm happy for any questions after. So I'm not going to teach you how to suck eggs. We all know where we find the bone marrow. It's in our long bones. And this is where we have our hematopoietic stem cells are found, which give rise to all of our blood cells. This process is called hematopoiesis and is the process by which all mature blood cells are produced. So from this one mother cell, we have the tri-lineage of cells, our erythrocytes, red cells, thrombocytes, platelets, and granulocytes or white cells. And the average person produces more than 500 billion blood cells every day. And this cell production line we've all seen before, but really sort of emphasizing that one hematopoietic stem cell, the mother cell, as the starter of all our blood forming cells. And when we talk about aplastic anemia, we are talking about a pancytopenia or low blood counts, a hypocellular marrow or an empty bone marrow. And what we need to differentiate here is there is the absence of any clonal abnormality, i.e. whilst the cells which are coming through from the bone marrow are severely reduced in number, they are not abnormal, they are normal. This is the difference between a non-malignant bone marrow failure and potentially a hypoplastic MDS, where the cells coming through will be dysplastic or abnormal. And you don't see fibrosis or increased reticulin in the bone marrow in aplastic anemia. And they need at least two of the following, so a hemoglobin of less than 100, platelets less than 50, neutrophils less than 1.5, and a low reticulocyte count. Just to put it into context, in the hospital where I work, a normal hemoglobin is 115 to 155, platelets 150 to 450, and neutrophils 2.2 to 6.3. But of course, we have to make sure that this bone marrow aplasia is not due to other treatment, or that it's not drug induced, or like induced by a viral infection. And aplastic anemia or is generally an immune mediated bone marrow failure, where the immune system starts attacking the stem cells in the bone marrow. So we get this attack on hematopoietic stem cells by the immune system. And interestingly, anything can trigger this event and be the assault on the bone marrow. And this can be a viral infection, a course of antibiotics, a vaccination, and even we've observed some aplastic anemia patient. Yes, hello.
Kindly move your mic a little bit away.
Is that better?
Yeah, now it's okay. Thank you.
Thank you. Yep, and even we've seen some patients who have developed aplastic anemia after COVID infection. And so you get this pathophysiology of stem cell depletion, a hypercellular marrow, and pancytopenia or low blood counts.
Hello, Simon.
Hello there.
Yeah, can you move a little bit farther? Your microphone?
Does it need to be closer to me or further away from me?
Yeah, further away from you.
Shall I continue?
Yeah, sure. Thank you.
Yeah, I'm so sorry. I'm not sure. Anyway, so with a new aplastic anemia patient, there's a few diagnostic tests that you will want to do. Obviously, a bone marrow is going to be really telling. You're going to do an aspirate and a trophine to look at the cellularity of the marrow. We always do a myeloid gene panel at this stage, and the King's gene panel comprises of 33 gene mutations which are associated with myeloid disorders or can show a predisposition to myeloid diseases, malignancies. We do CT chest radiology, because in some cases of patients who have constitutional bone marrow failure, you may see early signs of either lung fibrosis or liver fibrosis, particularly if we're suspecting they have short telomere syndrome or a telomeropathy. We want to do genetic testing, so to exclude Fanconi anemia, and we're also doing constitutional bone marrow failure gene panels, which I'll talk about briefly in a second. And we're doing sort of full blood work, so full blood count, reticulocyte count. We're doing a full virology screen. We want to do anti-neutrophil antibodies. We want to also look for the presence of a PNH clone. PNH, as we know, stands for paraproximal nocturnal hemoglobinuria. And in this bone marrow failure, the red cells are missing cell surface markers, which makes them prone to attack and hemolysis or breakdown of red blood cells. And in aplastic anemia, about 50% of our aplastic anemia patients have a PNH clone. Whether that clone is subclinical or is larger and needs some management, but it needs monitoring. And I'll talk a little bit more about PNH clone later. So what we're also doing at this stage is going to try and differentiate between an immune-mediated acquired idiopathic aplastic anemia or a constitutional bone marrow failure, a genetic bone marrow failure. And so what we need to do at this stage is be a really good historian, because if you have a patient who presents to you and they're going to present with, increasing fatigue, shortness of breath, more infections, opportunist infections, chest infections, urinary infections, they will present with active bleeding, whether that's from the nose, whether they're having retinal bleeding or subconjunctival bleeding, or just increased spontaneous bruises or bleeding when they brush their teeth. So they come in, this is your patient, they've got low blood counts, you suspect aplastic anemia, but you want to distinguish between, as I said, an immune-mediated or a constitutional. So what you want to try and do is see if you can find a normal blood count. Because if, for example, this patient, we'll call them Joe Bloggs, had surgery 3 years ago, they had a full blood count as part of routine assessment or screening, and it's normal, then we know we're looking for something to have changed from that normal blood count to where we are today. What could potentially be the event that has triggered your current clinical picture, your current presentation, your current low blood counts? Have you been on holiday and had a travel vaccination? Have you had a viral infection? Essentially, we give ourselves a bit of a window of where we need to sort of look a bit closer. If this patient, for example, has never had a normal documented blood count, but suddenly there's been a progression or their symptoms or the severity has worsened, and that's why they're with you today, we may start to think about a constitutional bone marrow failure, because these patients don't normally ever have a normal blood count. Even as a child or in their teenage years, they may have a documented abnormal blood count, but not abnormal enough to for them to show any signs or symptoms or have any constitutional symptoms. And also, right at this stage, we want to look at their family history. Do they have a family history of blood cancers, blood disorders, bleeding disorders? Do they
Simon, sorry.
Yep.
There's a noise friction while you're talking.
Let me see if this. So I've taken out the speakers. Is that better?
Yes, that's much better.
Okay, apologies, guys. So yeah, we're also looking at their family history. I spoke if they've got a sort of family history of diseases or autoimmune diseases, because this may
add to the sort of suspicion that their bone marrow failure is not immune mediated, it's genetic in cause. BHS guidelines have sort of said we need to do a personalized approach when treating aplastic anemia, and we'll sort of consider constitutional aplastic anemia in all patients, because essentially what this means for us as clinicians is if it's because of a faulty gene mutation, these patients may not need to be treated with immunosuppression because it's not immune mediated. So giving them things like ATG or cyclosporin will become futile because their bone marrow failure is not immune mediated, it's genetic, right? And the only genetic treatment will be a stem cell transplant. This is also really important when you're looking at donor provision. So if you suspect a constitutional genetic bone marrow failure, then you may want to just automatically exclude family members, siblings from donating, because they may carry the same gene mutations. Of course, you can do a gene mutation profile on them and test to see whether they have any abnormal, and these are things like RTAL, TERT mutations. There's lots of them which I'll show you in our gene panel next. But these patients, you may want to do an upfront unrelated donor transplant. So here are some of the inherited bone marrow failure disorders. And at King's, we do next generation sequencing with DNA extraction from white cells, and we've got these different subpanels. So we've got our bone marrow failure gene panel, neutropenia gene panel, and our thrombocytopenia gene panel, diamond blackfan anemia gene panel, and we've got many more. And so these are the sort of gene mutations we're looking for, and if we detect them, then this may be the underlying cause of their aplastic anemia. And then, of course, we've got our standard treatment algorithm. So when you're generally have an aplastic anemia patient in front of you, if they're under the age of 35, it says here, or 40 is generally accepted, and they have a matched sibling donor, you may offer them an upfront transplant. If they're under the age of 40, they do not have a matched sibling donor, then you're going to be looking at ATG treatment. And if they fail to derive a response to ATG treatment, at that stage, you may go for an unrelated donor transplant or a cord transplant or a haplotransplant, whatever the donor provision is that's available. In our older population of patients, we may go for upfront immunosuppressive treatment. So horse ATG plus cyclosporin is standard first line treatment. If they show no response at the 3 to 6 month stage, then we may add in additional drugs like altrombopag or platelet stimulator drug, or we may go for a sibling transplant or an unrelated donor transplant. I'm going to talk to you briefly about ATG and some of the sort of considerations when preparing a patient for ATG treatment. It is a horse-derived antibody. That's essentially you're taking the T cell or a T cell from the human, which we think is attacking the bone marrow. This is the immune-mediated attack against the bone marrow. It's popped into a horse, the horse makes antibodies, and you give the antibodies back to the patient as an infusion. And so it's a T cell depletion therapy. It's very powerful T cell depletion. And the idea here is that you give long-term immunosuppression along with the ATG, usually in the form of cyclosporin. And the idea is to try and dampen down the immune system, to try and stop that immune attack, and allow the bone marrow recovery time to sort of recover function, increase cellularity, and start producing more blood cells. It's given as an inpatient setting. The infusion's given over 4 days. Long-term immunosuppression is usually given for a minimum of 1 to 2 years, and it's generally tolerated really well, but you may get some generalized hypersensitivity reaction with fevers, rashes, hives, abdominal discomfort. Some patients get a bit of difficulty breathing, they may need some oxygen, but the infusion itself and the infusion reaction tends to get less on each subsequent infusion. The main thing to look out for here is this phenomenon of serum sickness, which is usually most at risk. Our patients are most at risk 7 to 14 days after their infusion. And then it's ongoing transfusion support. So this is where our patients from a nursing perspective need a lot of pastoral or emotional care, right? Because you've given them a treatment that's heavily immunosuppressive. It's got side effects. Cyclosporine, we all know, has got lots of potential horrible side effects. And they might generally be feeling a little bit worse than they did prior to starting treatment. And yet we're maintaining the status quo, waiting for this response at 3 to 6 months. They're still transfusion dependent, nothing much is changing, and it can be quite a difficult time for patients emotionally. Whilst you manage their expectations and tell them the projected timeline, I don't know about you, but AA patients often are very fixated and focused on their blood counts. I have patients who show me wonderful charts that will tell me that their neutrophils have dropped by 0.02% in 2 days, and their platelets have gone from 15 to 13, and they read into this quite a lot. And I think more so than in our malignant population, because in AML, you may get a post, you get your sort of dropping counts, for example, post chemotherapy, but there's also that regeneration and then recovery of blood counts. So it's more cyclical, right? You give a treatment, drop in blood counts, regeneration. In aplastic anemia, this is the norm. They've got low stem cell numbers, and so I often find them much more fixated on very minute changes, or what I would call a sort of a change that's so minimal it has within a normal varying fluctuation. It can often cause them a lot of anxiety. And so lots of TLC care. And I often encourage patients not to get fixated on numbers. This gives you a snapshot of what's going on in their bloods at this time. So many influences, factors which will change your blood count day to day, right? So you want to encourage them to look at the trend. Is it stable? Is it going up? Is it going down? How far apart are your transfusions getting? And how do you feel? More importantly. So ATG is sort of standard frontline, heavily immunosuppressive treatment, but we do see lower response rate in ATG in our severe category of aplastic anemia and in the older population. And this is just very simply shows you a study that looked at the response rate of ATG in sort of 18-year-olds to 70-plus-year-olds. You see a 52% compared to 46. Not a huge difference, but it is something to consider. And then when you look at disease severity, you're looking at a response rate of 89% in the non-severe category and 23% in the very severe aplastic anemia group. And so if we're not doing ATG treatment, we're going to be offering transplant, whether this is upfront sibling donor or a unrelated donor due to refractoriness or unresponsiveness to immunosuppression. All our patients are going to go through standard organ assessment. A lot of our patients may require iron chelation prior to starting treatment, because they're heavily transfusion dependent. They've got accumulation of iron, and we know that going on to transplant with a lot of iron on board will increase your transplant related mortality. It can increase graft rejection or graft failure, so we may need to look at trying to offload iron with medications. Also, aplastic anemia patients almost have a luxury in the sense that we can always offer fertility preservation. In our male population, much easier to do. In our female population, we often have to give hormone stimulating, so to stimulate eggs production and then collect them. It has to be timed with the menstrual cycle, but also patients who have a sort of moderate PNH clone. Like, PNH is one of the most thrombotic diseases there is, and so is the sort of hormone therapy you need for egg stimulation. So in this patient population, we may sometimes need to give them anti-complement therapy with Solaris or Ocluzumab to help manage their clot risk. Of course, this is only AA patients with a moderate PNH clone. And the procedure is difficult, right? Because they've got an increased bleeding risk because of thrombocytopenia and an increased infection risk because of neutropenia. So even simple dental procedures can be much more difficult. They are generally, they're anti-cancer treatment naive patients, i.e. they haven't had inpatient stays with chemotherapy like our AML population or lymphoma population. So it's all new territory for them. So there is increased emotional support. And our patients are heavily transfused, so there's the risk of platelet refractoriness or the development of antibodies in red cells, and that can also mean you can develop antibodies towards donors. It's things just to consider pre-transplant. We tend to do FCC conditioning, so fludarabine, cyclophosphamide, and Campath, and using high doses of cyclosporin and aiming for higher levels to sort of reduce their risk of graft rejection and graft versus host disease. I've put here that mixed chimerism is acceptable in aplastic anemia, and it is to a degree in the sense that post-transplant, if you have a mixed chimerism, that the recipient sort of cells coming through, it doesn't really mean as much in the sense that because that doesn't equate to a relapse risk, right? There's no cancer here that we're worried about. So if they've got a normal blood count, a sort of stable mixed chimerism is acceptable. You wouldn't necessarily want to give donor lymphocyte infusions because it increases the risk of graft versus host disease, and we're not trying to prevent a cancer relapse. And that brings me on to, and I'm coming to the end, I realize I'm over my time, for a review that, is there a change? Should we look at giving unrelated donor transplants in severe aplastic anemia up front? The pediatric setting, this is already standard care, but in the adult setting, it's not. And there are risks of ATG in the long term, i.e. it's not seen as a curative option. And we see about 10 to 15% of patients post ATG at the 10-year mark have clonal evolution to MDS or AML. We also sometimes see clonal expansion of PNH clone after ATG treatment. So if they've got a small clone to begin with, often as their cytopenias go down, we can see their PNH clone get larger, and then they can develop hemolytic PNH. Again, that's in this sort of 10 to 15% category. And the other thing we need to be very mindful of is stressed hemopoiesis in this patient population, right? Because for ease of, to make it sort of easy to quantify, I always sort of tell patients, imagine you've got 10 stem cells in your bone marrow, 5 of them making all of our blood cells, 5 of them are dormant. And in times of additional demand or stress, whether you're going to run a marathon, whether you become pregnant, whether you get an infection, and we need more blood forming cells, these 5 dormant cells come in, start making more blood cells, they help the deficit, they help, that they're sort of these troops that come in and help out. And then they go back into being dormant. In an aplastic anemia patient, they can't afford to have 5 stem cells sleeping doing nothing. They've got an empty bone marrow, right? So all of their cells are working very hard and they get stressed hemopoiesis. And it's when you've got this rapid proliferation with no respite that errors can occur. And these errors can potentially become dysplastic changes or malignant changes or lead to a blood cancer. So there is the question about whether we do matched unrelated donor transplants up front. And this is just sort of showing you how the gap is closing between response rate or overall survival in sort of sibling versus unrelated donor transplant. This is sort of split by risk, low risk, intermediate risk, and high risk. And if you look at the intermediate risk, the overall survival of sibling transplant versus unrelated transplant is margin is 77%, 78%. Whereas before, you know, we would see maybe a 5–10% difference between the two populations. And then you really have to question whether transplant is the right treatment up front, where there is a mortality rate associated with it and ATG not so much. So if you've got a good treatment that's not as toxic, it would have been before worth exploring that as frontline, which is standard practice now. But now we know about all of these potential late-term effects, and the gap between sibling and unrelated donor outcomes is getting smaller and smaller, and outcomes are getting better. This again is just showing unrelated donor data, looking at CAMPATH-related regimes. I won't go into it too much because I realise I'm over time. But I want to sort of leave it on a sort of nursing perspective, and as part of my role, as I often ask patients to do, we do a holistic needs assessment. So I send them out a concerns checklist. This is a Macmillan initiative, which is a big cancer charity in the UK. And patients are invited to sort of score on 1 to 10 sort of concerns they may have. These might be symptoms, education, work, sex, you name it, it's all there. And I sort of looked back at all the care plans and the holistic needs assessments I did on our AA population over a year period. And interestingly, although not unsurprisingly, but it did sort of shock me to see it in black and white, actually all the top concerns that my patients selected were pastoral in nature and not symptoms. So it was more about feeling angry, scared, frightened, low in mood, anxiety, that sort of uncertainty of their disease. And that just sort of highlights to me the importance of sort of early intervention with psychological support. And actually sometimes we're very good at assessing symptoms, right? You come in, you've got a symptom checklist or a toxicity checklist, you go through everything. And I try to, you know, if I see a patient, I've got them for 20 minutes, I'll say, let's talk about symptoms for 15, but I'm going to say 5 to talk about how you're doing emotionally. I think that can be quite good practice to get into, but it's not always easy in the confines of our clinics and time. But summary, sort of a conceptual approach to treatment. I guess the take-home message is you want to distinguish between immune-mediated and constitutional, because the treatment that you offer is going to be very different. There are also gene mutations which are favourable and unfavourable for immunosuppression. So if you detected a B core mutation, for example, that's a favourable, that they would respond well to immunosuppression. Unfavourable might be things like
Sorry, Simon, you have 2
yes.
minutes. 2 minutes. Okay,
yes, sorry. I could talk about aplastic anemia all day, so I do apologize. But there are some unfavorable mutations, like a RUNX mutation or many others, and there is consideration of doing upfront transplant in these patients as well. So lots to consider, lots of pastoral care, really.
Management na siya.
Yeah, absolutely. And on that note, I will say thank you, and I apologize for all the technical difficulties that I've had. Sound a bit like Mariah Carey there, but please, I welcome any questions that you may have, and thank you.
Thank you so much, Simon. So for any question later on, because we will be moving for the third speaker, so keep online, please.
Thank you.
Yeah. The next speaker is Miss Inam Shahabidin. So she graduated with Bachelor of Science in Nursing from Maqasid College of Nursing and Health Sciences from Beirut, Lebanon, and carried on to complete master's degree in healthcare administration from Saudi Electronic University, Riyadh, Saudi Arabia. Currently, Ms. Shahabidin is an adult stem cell transplant nurse specialist in stem cell transplant and cellular therapy division in Department of Oncology, Ministry of Health of National Guard, Health Affairs, Riyadh. Ms. Inam will be talking about the Saudi Blood and Marrow Transplant Registry. Ms. Inam, please welcome.
Yeah, thank you. Thank you, Jennifer, for the nice introduction. Thank you for inviting me to be part of this. This is Inam, and I am adult stem cell transplant nurse specialist at King Abdulaziz Medical City, Riyadh. I will be presenting an overview on Saudi Blood and Marrow Transplant Registry. Let me share my presentation. Okay. Can you see the slides now?
Yes, but kindly maximize it. Kindly press 5.
Okay. Okay. Okay, so moving forward, is it clear now? Yeah.
It's still not maximized here.
Okay, can I start?
Okay, now it's perfect.
Okay.
You can start now.
Okay. So first, I will be presenting the objectives. So when we first have established this registry, the aim or the purpose was to provide insights on disease trends, outcomes, treatments, and patterns of care for patients who have hematological malignancies and underwent stem cell transplant in Riyadh, in Saudi Arabia. Sorry. So this is more to estimate survival rates and regional trends across the kingdom. So first, it was a collaborative national project between Saudi Society for Blood and Marrow Transplant and King Abdullah International Medical Research Center. It was first launched in December 2015. And currently, we are the only center enrolled in this registry at King Abdulaziz Medical City, Riyadh. We are looking forward to inviting more centers to be involved because this gives us more information on the regional trends of our patients. So in SBMTR, we look forward and we make sure about the quality of our data, that our data is accurate, reliable, consistent, and timely, validated, verified, and we make sure that data privacy is maintained. So currently we are 2 nurses who feed this registry. Each nurse has her own username, which is password protected. Our passwords are not shareable, not transferable. We do also regular internal audits where for our data accuracy. Our minimum error rate for our critical fields should be less than 3%. And we do a lot of proofreading and data cleansing process. So up till now, there are more than 7 published articles out of the data collected in this registry. So who are the patients who are enrolled in this registry? All patients who underwent stem cell transplants will be enrolled. So upon entry, each patient will be followed prospectively until patient death or loss of follow-up. We gather data on disease characteristic, clinical presentation, patient demographics, staging of the disease, genetic makeup, treatment patterns, short and long-term outcomes specific to Saudi Arabia population. So this is our compliance rate. So far, we have started our transplant program in 2010. We have done 427 allogenic cases and 241 autologous cases. So out of 427 allogenic cases, 422 are entered so far. All are entered, sorry, but 422 are complete. The remaining 5 we have pending engraftment data. That's why our compliance is 98.8. For autologous, we have 100% compliance rate. So we have 3 pillars: data collection, data submission, and data retrieval. So in regards to data collection, we have 3 forms in the registry: pre-transplant form, day 100 form, and annual form. The pre-transplant form talks more about the general data, patient demographic, including type of transplant, disease or diagnosis and subclassification, comorbidities, labs, donor information for allotransplants, diagnostic data, cytogenetics, molecular disease risk score, and status of disease at transplant, and treatment regimens being used. The 100 form is more about preparative regimen and stem cell graft, mobilization, infusion, engraftment, complication, and disease evaluation at day 100. If we have given any maintenance, consolidation, or maintenance therapy post-transplant, and GVHD data. Our annual forms consist of date of last contact and assessment of the patient, post-disease therapy as of day 0, cellular therapy and latest chimerism results. For example, if patient was given DLI, annual lab work, post-transplant late complications, secondary malignancies, survival status of the patient, and latest disease evaluation along with GVHD data. So the registration of the patients is a continuous process. It is carried out throughout the year. We usually initiate the entry or the visit on the registry at the day of the transplant or at the start of the conditioning regimen. The remainder, day 100 and annual data, we do it at the time of, on time, at the time of death, or whichever occurs first. So how do we retrieve our data? We can always, so SBMTR appreciates really how important to access the data so that they can do research, publish manuscripts based on this data. So we can access our data directly, or for each patient, we have like data summary sheets for each form actually. Like we have a data summary sheet for pre-transplant form, day 100 form, and annual form. So these are the publications so far that were done based on SPMTR registry. And now I will be showing a video that shows an overview on our real CRF or the stem cell transplant registry software.
Okay, so now we are going to explore the real SBMTR CRF. This example is for demonstration only. As you can see, this is the initial page. You can see the registry name, date of your entry. You can view your entry from here. And we have 3 categories: pre-transplant, day 100, and the annual visit. So if we press here to view our entry and I go to pre-transplant category, this will open 7 pages. Page 1 is about general data, demographics in general, transplant center and type of transplant. Then pre-transplant data, initial diagnosis, date of initial diagnosis, and the referring institution, or if the institution is ours. Page 3 goes to diagnosis. For example, if I press Hodgkin lymphoma, and I go to page 7, it gives me the subclassifications of the Hodgkin lymphoma, if there was any B symptoms, bulky disease, extranodular, and other information about Hodgkin lymphoma and the treatment, the induction chemo, salvage chemo, radiation, and whether the patient has taken brentuximab or rituximab. Okay, if we go back to diagnosis, for example, and I press bone marrow failure syndrome, and then I go to page number 7. Let's go by this. So it opens bone marrow failure syndromes. The classification, Fanconi, dyskeratosis, diamond black fan, and others. And the treatment pre-transplant or any complications. So each diagnosis has a specific subclassification on page number 7. So we go back to page number 3. We have other information, height, weight, BMI, and performance score, then comorbidity conditions, then the comorbidity index for the transplant. For example, if I press Crohn's, it gives me 1. If I press SLE, it gives me 2. If I calculate, it gives me 3 auto calculation, or any invasive fungal infection history. Page number 6 is about lab work up on diagnosis, and page number 7 is about the subclassification. We talked about this before. So I save and exit. I go now to day 100. Day 100 report starts with the date of last assessment. It should be within day 100 plus or minus 10 days. We see here like at least one dose of the preparative regimen was given. If I press no, it doesn't open anything else. If I press yes, it pops out a question. Patient died during preparative regimen. If I press no, it gives me date of starting of preparative regimen and date of discharge, and then auto calculation. We go to page 2. This is information about preparative regimen. Type of preparative regimen, myeloablative, RIC, all the types, CTBI, TBI, flu-bu, or others. And intent, myeloablative or not. For example, if I press, melphalan was used, for example, for myeloma patient, I have to give the dose and the unit to enter the dose and the unit. If the ATG is used, whether yes or no, and radiation therapy is used, whether yes or no, and you have the types of radiation therapy. Page number 3 is about stem cell graft information. If it was bone marrow, cord blood, peripheral, and the type. If we have graft manipulation and I pressed yes, so it gives you multiple options like RBC depletion, cryopreserved plasma depletion, CD34 selection, and so on. Page number 4 is about stem cell dose and mobilization, the source of stem cell collection, place, date, the line inserted, total CD34 and TNC collected, and total volume collected, complications post-transplant if it was line-related, mobilization, mobilizing regimen-related or procedure-related, and you always have others as an option. Then stem cell infusion. If it was infused, it gives you how much, the date, the dose, total CD34 dose, the route, if test was performed on a reference bag, for example, and the method used, complication during infusion, it gives you a free text, and the cell viability, which usually is given by our stem cell lab team. Engraftment data. For example, if I press yes for ANC engraftment, the first date of 3 consecutive days where ANC were more or equal to 0.5. Chimerism, we have day 30, day 60, and day 90. Chimerism, if I press mix, I have to enter the total number. Labs upon day 100. Post-transplant complication, we have the most common complication. For example, if I press mucositis, it gives me the grading system. If I press febrile neutropenia, I have to enter the date. CMV infection, I have to enter the date, and so on. And if any positive microbiology culture were detected, and the name of the organism, and you can always add more. Page number 10 about whether a new malignancy, the patient experienced new malignancy different from the disease that he was transplanted for, and it gives you many options, and there is always an area to enter other option that is not listed. This is the disease evaluation. On day 100, the patient was already in CR. The patient has achieved CR post-transplant, never in CR or not evaluated. If the patient achieved CR, I have to enter the date. You notice here we have CR, stringent CR for multiple myeloma, partial remission, very good partial remission, and so on. Method of latest disease assessment. How did we assess the disease? Molecular, like BCR, ABL, the date, whether the disease was detected or not, cytogenetics, bone marrow biopsy, PET scan or CT scans, and whether a previous transplant was done for a different disease than the disease that he was transplanted for this transplant. Additional post-transplant therapy given. If we press yes, you have the different drug options. For example, if I press dasatinib, it gives me the time post-transplant was started, duration in month, and how many cycles, for example, for brentuximab. Indication of post. Why have we given post-transplant therapy? Was it planned maintenance? Was it prophylactic treatment of GVHD, mixed chimerism or lost chimerism, treatment of disease, and others? Page number 14 in day 100 assessment, whether the patient is alive or died. If alive, it gives you the ECOG score, performance score. If died, then this will pop out. You have to enter the date of death, number of days post-transplant, the patient died, and main cause of this. Was it disease-related, relapse, new malignancy, transplant-related, or unknown, or others? So this was day 100. If we go to annual, the first page is whether the patient has lost of follow-up, yes or no, and what was the last contact date and what was the last assessment date, whether he lost follow-up or he's still following up with us. GVHD prophylaxis post 100 days continued. For example, if I press yes, for example, cyclosporine for aplastic anemia, it gives you for how many months? Like 6 months. For post-transplant disease therapy, as of day 0, the same. If we continued to give this therapy post day 100, and what is the therapy? The cellular therapy given whether yes or not, for example, DLI, total dose, donor cellular infusion, was it planned, was it mixed chimerism, what was the reason, and the response, and the maximum, whether the patient experienced GVHD from this secondary to this cellular therapy. Then we have if the patient had secondary graft failure, last chimerism assessment and date of last chimerism. Annual lab workup. We have different annual lab workup. The CBC chemistry profile, the myeloma workup, and so on. Post-transplant late complications, you have here the most common complications. For example, if I press hepatic, it gives me iron overload, viral hepatitis, or GVHD. If I press respiratory, it gives me idiopathic pneumonia syndrome, bronchiolitis obliterans, or a cryptogenic organizing pneumonia, musculoskeletal, avascular necrosis, osteoporosis, or steroid myopathy. So each option gives me pops out other options to select. CMV infection, whether we had CMV, the number of CMV infections, and the date of the event, and how was it treated. Was it a complete response, partial response, or it was resistant? And other infections, for example, if I press pneumonia, I select pneumonia, I have to enter the date of diagnosis. For other complications, I have also free text for complications that are not listed here. The same here, whether a new malignancy has appeared at annual follow-up, then the survival status, Then the evaluation of the disease at annual visit. If the patient experienced first relapse or progression, was it detected by molecular, cytogenetic, hematology, or radiology? And method of latest disease assessment, the same as before, but we have here an extra question that whether the patient or the partner become pregnant after this transplant, yes or no. So this is for the annual, and this was a general overview of our SBMTR registry.
Okay, so this was a video exploring our registry. Before the end, I want to stress on something that is very important in data collection, which is that all our patients are consented. It's part of our consent for transplant. Actually, our consent has 10 items. Item number 9 is about data collection and research, and it is listed clearly that the data of the patient will be used in national and international registries, and the data will remain confidential without mentioning the name of the patient. So this will keep it private. So by this, I come to the end of my presentation. Thank you again for being part of this, and I'm ready for any question, if there is any question.
Oh, that's quite a registry. So, Miss Inam, I have two questions for you. So, how does a healthcare institution will take part on this registry, and how to undergo any training, if in case?
Yes. So as I have mentioned, we are the only center who is enrolled now in the registry, but we are in the process of inviting other centers to be part of this and start feeding the data. Any training? Yes. We have taken a training session from KMAR, King Abdullah International Medical Research Center. Currently, we are 2 senior nurses who are feeding this data, who are very competent to do this. We have been doing this for 5 years now. And of course, for anybody who is interested to join, we will have training sessions for junior data registrars or encoders.
Okay. I think we still have time. So, Simon, are you still there? Simon? Simon? Okay. I think we will conclude this second session. So we will have short breaks after 10 minutes, hopefully. We'll see you again. And to all the nurses, happy Nurses Month, and make us proud and make a difference. Thank you.
Thank you.
All right. Good afternoon, Saudi Arabia, and to the rest of the world, good morning, good evening. I know it's been a long 3 hours. 2 sessions have been finished, and I hope our participants are still awake. Come on. We have 3 more exciting speakers that will give and share their knowledge and experiences with their topic of choice. So let's start with Mr. Musumati. Mr. Lohanga Musumati is currently employed as a clinical nurse specialist in the benign hematology in National Guard Hospital, Riyadh, wherein for the last 2 years, he is involved in leading nurse-led clinics with thrombosis and hemoglobinopathies. Aside from these clinical duties, he is also highly involved with thrombosis research and teaching responsibility. He started his general nurse from Kitwe College of Nursing in Zambia and relocated to the UK, wherein he started as staff nurse in a hematology ward. Subsequently, he completed his master's degree at he completed his bachelor's degree at Wolverhampton University, and after that, master's degree in King's College, University of London in 2012. His last post before joining National Guard was at Guy's and St. Thomas Hospital in central London, where he worked as an advanced nurse practitioner. Mr. Lohanga, the floor is all yours. Take it away.
Hi there. Thank you. Thank you very much, Annalie, for that flattering introduction. I appreciate that. So my job is very simple. I'm just going to give our audience a very quick overview of on thrombosis, but I'm going to focus mainly on hospital-associated venous thromboembolism prevention. This is quite an important part of my role, but I think it's just as important for everyone on this panel. If you're working in hematology, oncology, this would be something relevant to all of us. So I'm just going to share my screen and make a start on that. Okay, I hope everybody can see my screen. Is that correct?
Lito started the screen sharing, double click to enter full screen mode. Right, okay. I think there's a few things on my screen, trying to decongest that. Apologize about this. No worries, we still have time. By the way, you got 25 minutes to prepare your presentation, right, or to give your presentation. And 5 minutes for the Q&A. There we go. Okay, I think we're ready to go, right? Thank you. Right, okay, yes. So my name is Lohanga, as introduced, and I'm going to give an overview of hospital-associated venous thromboembolism, abbreviated HAVTE, specifically within oncology. So I'm hoping that by the end of this session, we'll be able to define what hospital-associated VTE is, describe the pathophysiology. We'll look at the list of risk factors, the signs and symptoms, as well as long-term complications. We'll try and describe the role of the primary nurse, because I think that's where it really all boils down to look at what the nurse can do in this situation to prevent patients coming into our department, on our wards, from developing clots when we're supposed to be looking after them to manage other conditions that they've come into the hospital with. Now, the definition for hospital-associated VTE is simply is a term. Hospital-associated VTE is an umbrella term describing deep vein thrombosis, abbreviated as DVT, or pulmonary embolisms, which happen during admission or within 3 months after the patient has actually left the hospital. So about 50% of VTE cases occur during or after hospitalization, making it a leading preventable cause for hospital death. And up to 70% of these cases can be prevented
if patients are assessed properly on admission and started on the appropriate thromboprophylaxis. And this can either be pharmacological or mechanical methods. Now, the Joint Commission for International Accreditation, JCIA, identifies VTE prevention as a critical patient safety measure, and hospitals are required to take steps in actually evaluating the services we provide to ensure the safety of our patients. Now, for our colleagues in the UK and probably somewhere else in Europe, UK particularly, JCI will probably, the equivalent of JCI will be the National Institute of Clinical Excellence, NICE. Now, of course, I'm biased. I work in hematology, oncology, so I would like to highlight the significance of malignancy and its role in VTE. And so this is one study published in 2015 in the Natural Review Cardiology Journal, and it shows cancer patients are have a threefold increase in the risk of developing VTEs while they're in the hospital compared to their non-cancer counterparts, as you can see in this Kaplan-Meier curve here. Incidentally, they also happen to be at risk for bleeding complications as well. Once they start on anticoagulants, their risk for bleeding is much higher as well compared to other non-cancer patients. As you can see in this curve here, the cancer patients were high up there and the non-cancer patients are lower there. So it's about 2 to 3-fold increase in the risk for bleeding complications. So this really highlights why we need to have put a spotlight on our patients coming into our departments. In terms of the pathophysiology, the ability to sort of look at the pathophysiology of DVTs really properly is based on this gentleman's triad, Virchow's triad. Virchow is a German doctor who we would say he was a pioneer for thrombosis. So he put forward these 3 categories as the sort of the highest predictors for thrombus formation or for thrombosis happening. So venous stasis, the inability for blood to flow at a particular at a certain pace. If the blood flow is slowed down, then that increases the risk for thrombosis happening. Vascular injury, if there's any damage to the blood vessels, blood has a tendency to try and stop the bleeding by activating the clotting mechanism. And so that will be another factor. And then, of course, hypercoagulability. This can be due to genetic factors. There's a lot of people with genetic conditions which predispose them to developing clots, such as protein C, protein S, antithrombin factor, Leiden, factor 5 Leiden, and so on and so forth. So once a clot is formed, it can begin to slow down the blood flow. Now, the patient might not be symptomatic straight away. However, as the clot progresses, the patient will become symptomatic, and so end up blocking the blood flow. And of course, sometimes this blood clot can actually dislodge. A fragment of that clot can dislodge and begin to travel through the blood circulation. And as you can see in this cartoon here, I pinched this from Google. You can see the blood clot forming just underneath this valve, and then a fragment of that dislodges, that becomes an emboli, and it ends up in the lungs, for example, where the blood vessels are much more smaller compared to the original location where the blood clot forms. So the primary source usually is the calf muscle in the leg. And then once that dislodges, travels around the body, it can end up in the lungs or even sometimes in the brain, causing a stroke. So the risk factors, they're sort of stratified in 3 areas. So we have the strong risk, and the ones highlighted in red are probably the most common. So acute illness. So hence the reason why anyone really who comes into the hospital, not just the cancer patients, but anybody who is admitted to the hospital with an acute illness has an increased risk of developing a clot. The risk increases from day 2, day 3. If they're acutely ill, then they become they have an increased risk for developing a clot. If they already have a previous history of a VTE, if it's happened once, it's likely to happen again. Reduced mobility, this can be either by doctor's orders because of other conditions happening, or it might be because of the patient's own limitations. So if they're limited to just bathroom privileges only, that is classed as a limited mobility. So patient actually needs to be able to step out of the room, walk at least the full length of the ward and back again into their room to sort of minimize that risk. But if they are limited to their bed for at least 3 days, then that puts them at risk for developing a clot. Long duration travel, of course, more than 4 hours. And this applies to all of us really, when we're going on holidays or whatever we might be doing socially. Surgery is also gives an increased risk, particularly if it's a hip surgery, knee, or cancer-related surgery. And cancer, of course, which you've already mentioned, it has a fourfold increase in causing VTEs. Then this classification here for the moderate risk age. Obviously, as we get older, we begin to slow down. We're not as busy and active as we would be when we were much younger. Family history, if there's a history of clots, it's probably genetic. There's a genetic predisposition. And so somebody who has a strong family history is also likely to develop a clot. Cancer or being on chemotherapy is also a risk factor. Trauma, we've talked about vascular injury, or hormone replacement therapies. And the last category here, other factors include obesity, pregnancy, or recent childbirth. This is associated with hormonal imbalance, but also usually the mother will be restricted to sort of looking after the baby. And so their movements might be restricted as well. And of course, smoking. Now, in terms of signs and symptoms, if somebody who develops a DVT, these will be some of the things we'll be looking out for: pain and tenderness in the limb. As you can see in the picture here, usually this is the sort of typical presentation. There's asymmetry in the legs. One leg tends to be bigger than the other one. It's painful, shiny, skin is stretched. However, it's important to mention also at this point that sometimes occasionally people can also have bilateral DVTs, and they can actually present with 2 swollen legs, or sometimes the DVT is actually sitting much higher than the calf. It might actually be in the groin, so the leg could swell all the way up to the groin area. So just something to bear in mind. The diagnosis for this, obviously, usually it's an ultrasound. This person will go for an ultrasound, and they'll be able to visualize the vein and see the blood clot sitting in the vein. Occasionally, they might do a venogram, which is an X-ray, which involves a dye to be able to visualize where the clot is. For pulmonary embolism, this is usually it's a critical situation. It's a medical emergency. Sometimes, or in fact, in most cases, the symptoms happen very suddenly. So there'll be unexpected shortness of breath, rapid breathing, chest pains, worse on deep breathing, tachycardia, sometimes lightheadedness or passing out. And so this patient might be, they'll be well, an hour, 2 hours ago, and then suddenly they develop these symptoms. In terms of the long-term complications, so once somebody's had a PE, they are likely also to develop a condition called chronic thromboembolic pulmonary hypertension. Now, this is usually, they might have multiple PEs for them to develop these complications. It's rare, but it can be potentially life-threatening, and it happens in approximately 0.6% of patients who've had a PE. Now, what happens here, as you can see in this cartoon here, normally your blood vessels are nice, wide open, perfusing the lungs, circulating blood to the lungs. However, when a clot happens in the blood vessels in the lungs, the clot, sometimes the unresolved clot, can become fibrosed, and actually become part of the muscle of the blood vessel. And so this reduces the lumen of the blood vessel, as you can see in this portion here of the cartoon. So as the lumen of the blood vessel reduces, it increases the pressure. And so this patient will end up with right side heart failure with life-limiting complications, difficulties in breathing, reduced exercise tolerance, and so on and so forth. So PEs, which are happening secondary to DVT while the patient is in our care, is a terrible thing to happen. It is preventable, and hence the reason to really flag these things up and actually talk about them. Another complication is post-thrombotic syndrome due to impaired venous return. This will happen in the limb, as you can see this gentleman here. Again, this is damaged blood vessels from the clot, which sort of becomes part of the blood vessel unresolved due to remodeling of the blood vessels. So it limits the perfusion and the stagnation of venous return, and damage to the blood to the tissues as well due to impaired blood supply. So this also has it's a disability really affecting this individual, and really causing limitations to the lifestyle in a very substantial way. Some of these can even lead to litigation, leading on to healthcare costs if the family or this individual decides to sue the institution for developing something that could have been prevented. So we have adopted our model of care as a multidisciplinary approach, beg your pardon, as a shared responsibility approach. So we take patient care as a shared responsibility. Patient safety is not just one individual's responsibility. It's not just for the doctors, not just for the nurses. So we've started a project which I'm not going to go into today. That will be something for another day, but I'll sort of just share snippets of what we are actually doing at NGHA. So this is our NGHA VT project where the nurse is actually initiating the assessment, and this is co-signed by the physicians. The reason for doing that is to make sure that no patient is slipping through the net and not being assessed for the risk of VT on admission, as well as the risk for bleeding on admission. And so we've taken it as a joint responsibility between the nurses, the physicians, the patient educators, the physiotherapists. So it's a big project, and we're very excited about it. Just watch this space in the next 12 months or so. Perhaps we might be able to present on the outcome of this. That's probably me marketing myself for the next conference. That was a joke. Anyway, the goals for care in this situation are to prevent hospital-associated venous thromboembolisms through screening and timely administration of an inappropriate thromboprophylaxis. And this could be either pharmacological in the way of probably enoxaparin or any low molecular weight heparins, or it could be mechanical prophylaxis, such as pneumatic compressions or TED stockings, if there's any contraindications for the pharmacological interventions. So again, the next goal is to improve patient safety, reduce morbidity and mortality associated with hospital-acquired VTEs, prevent complications associated with treatment. So again, once we start the patient on anticoagulation, we also introduce the risk of bleeding. And we noticed from earlier slides that cancer patients or patients with malignancies have a much higher risk of bleeding as well. So we begin to be on the lookout for some of these complications happening. Reducing healthcare costs from unnecessary bed occupancy days. So if somebody was planned to be discharged tomorrow, and then today we discover that they have a DVT, and then on top of that, we realized they hadn't even been screened for VTE risk on admission. Now that's completely unacceptable. But of course, it's happened now, and so that patient ends up staying in a hospital bed longer than they really needed to be. But also, as I said, a PE can be a medical emergency. It's life-threatening. Somebody can actually, unfortunately, die. And in the event of a loss of life, that's really the ultimate. There's no price on that. We track performance with ongoing data collection to make sure that we're able to improve on the areas that we need to improve on and share good practice. And our goal is to increase the percentage of patients being assessed. With the nurses involved now, our goal is to make sure that there's 100% compliance with this particular task. So the role of the primary nurse is to ensure VT bleeding risk assessments are done on all admissions. So we've done a lot of work in educating the nurses to pay attention to this particular area and checking that the VT assessments have been done on admission. If not, then that's escalated to the primary teams. And when patients are identified as being at high risk, they need to be on some form of thromboprophylaxis. So daily assessments are ongoing and escalate any warning signs. We're also assessing for any bleeding risk for those who are already on anticoagulation. Education for patients, as well as the term sitter might not be familiar with other people outside of Saudi, but sitters is really just relatives who are actually accompanying the patient, sitting at the bedside. So sometimes patients come into the hospital and it's normal, expected to feel that, hey, look, I'm in the hospital, I'm sick, so don't bother me about being mobile. I just want to lie down and recover, which is it's not an unreasonable expectation. But actually, we've embarked on education to make sure that the patients are aware of the risk of sort of just lying down in the bed, as well as the sitters as well. And of course, we want to make sure that they are aware of signs and symptoms and what to look out for to make sure they're reporting these signs earlier on. So encouraging mobilization, and of course, getting the physiotherapists involved if there's any concerns about mobility for patients. We want obviously to ensure that patients being encouraged to mobilize, it's actually being done within reason and it's safe for them to do so to avoid any risk of falls as well. So ensure timely administration of appropriate prophylaxis and correct use of mechanical devices, below knee TEDs, compression or stockings or pneumatic compression devices. Patient education on discharge to make sure there's compliance with their use of anticoagulation, and also we educate them on what to look out for in terms of the bleeding risk, so that they're able to report those signs as soon as they are noticed while they're at home. And of course, we need to make sure that they understand the importance of follow-ups with the outpatient clinics to ensure their treatment is safely monitored and managed. So in summary, we recognize that hospitalization is a major risk factor for VTEs, and cancer patients are particularly at high risk for developing VTEs. Therefore, mandatory screening of all admissions within the first 48 hours. Now, 48 hours is the window for doing that, but really we should be making sure that every patient is assessed on admission. As soon as they come into our departments, we should be making sure that they're assessed for the risk, also the bleeding risk assessed, so they are on the appropriate prophylaxis straight away. If it's not done in the first 24 hours, then we also increase the risk of patients being missed, because the focus becomes managing the actual condition that they came into the hospital with, and we increase the risk of them being missed out on being assessed and being put on prophylaxis for VTE prevention. Timeliness of the appropriate thromboprophylaxis for all at-risk patients, ongoing monitoring. So we're monitoring on a daily basis. If there's any change in their clinical condition, if say, for example, a patient came in, they were fully mobile on admission, however, 2-3 days later, they develop neutropenic sepsis, they become stuck in their room, they are not mobilizing as much as they did, then we need to do another risk assessment at that point and make sure that they are actually on prophylaxis. Or if they are transferred from another department and we're meeting them for the first time, then again, an assessment needs to happen at that point in time. Patient education we've covered as really critical. This is about empowering the patient so they are aware of what the issues are, and if they become a partner in actually preventing these conditions happening, then it makes the lives of everybody else much easier. But most importantly, they become experts at actually looking after themselves and ensuring safety, their own safety. Encouraging mobilization and ambulation, as I said. So this is really all I wanted to share, and I hope that that was helpful. And thank you very much for listening. I'll hand back over to the moderators. Thank you.
Thank you so much, Lahanga. Actually, it's highly informative. I mean, oh, by the way, we only doesn't have licensed healthcare workers joining us. We even have nursing students who message me and enjoying our presentations from all our lecturers, our presenters for the past 2 sessions, including you. Like there's a review of pathophysiology in all the presentation, and they are so thankful for that. So basically, your presentation, there's no question on that. But I'm so interested on these nurse-led clinics, thrombosis area. Okay, so you know, thrombosis is a little bit in between, managed by hematology department or cardiology service. In your institution, in your practice, the nurse-led thrombosis clinic is managed by benign hematology, and so that's it.
No, so let me explain. So traditionally, patients coming in with VTs have tended to be managed by internal medicine because they tend to come through ER, so they will have their scans done and will be started on treatment. But recently, we have taken some of that work on into the hematology department because we believe thrombosis really, you know, if we should call it what it is, it belongs under hematology. And so we have taken over some of that work. So we are managing all the sort of more complex patients who require long-term treatment. So normally when patients have developed a clot and it's sort of provoked, we know there was a clear provoking factor, their treatment timelines are likely to be around about 3 months. But if there are other complications and the patients are likely to require monitoring and are likely to be on thrombo or anticoagulants for much longer, then they need to be managed by a hematologist. So they actually come to our clinics, and I work very closely with my consultant. So the idea of having a nurse-led clinic is to offload some of the workload from the consultant, so they can have create capacity to see much more complex patients.
Yes, I do agree with that one. There are a lot of institutions who have a nurse-led clinic, but the confusion is which one is which. Like when we talk about pulmonary embolism, pulmonary clots, the pulmonologists are handling that. So how the co-management will that be? Because I have seen scenarios that it's like stepping on each other's, you know, management is what I mean. So in your nurse-led clinic, would it be like, let's say, a complicated case of thrombosis will be a multidisciplinary approach?
There is a proportion of patients who are managed jointly. So we will manage them jointly with a pulmonologist as well.
Okay.
Yes, so I completely agree.
And lastly, I do agree that aside from nursing assessment, inpatient, outpatient, nurses play a crucial role on education.
Absolutely.
Very simple thing to do, but educating our patients and their families and primary caregivers are crucial on this part, especially when you describe all the symptoms. Now, my question is reporting. When you mentioned it, the family or the patient should report it promptly. Are we speaking of a face-to-face reporting, or there is some sort of telemedicine reporting, some sort, or even an application to report that I have the symptom? I'm just questioning because, you know, other institutions can also learn from other hospitals.
Yeah, I think telemedicine is probably the next step. At the moment, it's face-to-face. So what we're doing really is to make sure that the patients are aware of what the symptoms, because sometimes if the clot is not fully flayed, the patients might not have a swollen leg particularly, but they might begin to experience maybe a bit of discomfort in their calf. And we want to recognize that as early as possible. So it's really ensuring that the patients understand the role of keeping mobile and having that conversation with their primary nurse. And then if they feel anything that is unusual, then they need to report that straight away so that it can be actioned upon.
All right. By the way, we have a question from our attendees from Mohammed Bashir of King Saud University Hospital. His question is, how can we handle the challenge of thrombocytopenia patient who develop a DVT?
Yeah, that's it's a complex one, very tricky. Obviously, if somebody is contraindicated from receiving anticoagulants because they've developed a DVT, contraindicated for anticoagulation because of their thrombocytopenia. We've had patients who've ended up having an IVC filter, for example, just to prevent that clot from dislodging and causing much more serious symptoms. So that's just one of the things that could be done. But it requires a lot more careful planning and monitoring their platelets and all the other blood parameters to make sure that the dose is adjusted accordingly. I hope that answered the question.
Yes, you answered them well. Thank you so much, Lohanga, and nice meeting you through this virtual conference, inshallah. Next time, as you are already marketing yourself for the next meeting, we'll be face-to-face. All right, thank you so much. Let's move on to our second speaker. Maria Lozano is a hematologist at the Morales Meseguer Hospital in Murcia, Spain, and an associate professor at the University of Murcia. She is the current president of the Spanish ITP group. So we will be having the presence, the expertise of our Dr. Maria in presenting with immune thrombocytopenia. Dr. Maria, the floor is yours.
Well, thank you very much for the invitation to participate in this meeting and talk about immune thrombocytopenia, or also called ITP, which is the most common form of isolated reduced platelet counts. And in this disease, in the last 10 years, we have witnessed significant advances in the knowledge of the disease pathogenesis, and also in the availability of new treatment options. So this slide shows my disclosures. ITP is an acquired autoimmune disorder that can affect both adults and children, and is characterized by lower than normal platelet counts, below 100,000 per microliter. ITP may be defined as primary or secondary, based on how the disease is identified. In adults, ITP occurs more frequently later in life and usually becomes chronic, while in children, the incidence peaks between 2 to 6 years of age and is frequently preceded by an acute infection and generally resolves spontaneously. Thrombocytopenia may result in an increased risk of bleeding, putting patients at risk for serious complications, but the increased morbidity in ITP patients also includes increased risk for thrombosis, for infection, and for the development of other autoimmune disorders. Fatigue causes a high clinical burden of the disease, which can significantly impact the health-related quality of life. So at the end of the talk, it will be your turn to ask questions, but by now, and through this presentation, I would like to flip the roles and present some questions for you to identify the possible answers. The first one is, which of the following statements is not true? A, ITP may be caused by decreased platelet production. B, ITP may be caused by increased platelet destruction. C, the diagnosis of ITP is established by the positivity of antiplatelet antibodies. And D, ITP patients have an increased predisposition to develop other autoimmune disorders. And as we will see in the next two slides, it is not true that the diagnosis of ITP is established by the positivity of antiplatelet antibodies. Then, what is causing the decreased platelet count? Well, in the last decade, the multifactorial pathogenesis of ITP has become apparent, leading to the understanding that this complex and heterogeneous disease is triggered by the immune system dysregulation, potentially resulting not only in increased platelet destruction, but also in impaired platelet production. Additionally, the levels of thrombopoietin, which is the main regulator of platelet production, do not increase appropriately, which also contributes to the decreased platelet counts. And as for the diagnosis, although ITP treatment has advanced considerably in the past decade, the diagnosis of the disease has changed very, very little. And there is no reliable biomarker or gold standard diagnostic test. And while the search for such a test continues, the diagnosis remains clinical and possible only with the exclusion of other causes of thrombocytopenia. So for the typical ITP patient, the rule of thumb is to do as limited an amount of testing as possible after confirming that there are no findings on the history, the physical examination, or peripheral smear that suggest another process. So taking into the account the limitations of not having confirmatory tests, the misdiagnosis of ITP is very high, 1 in every 7 patients. So that clearly efforts have to be made to improve this area. So usually after an ITP diagnosis, the patients wonder why they have the disease and if they are prone to develop other complications. It's clear that genetics play a role in autoimmune disease, but that genetics alone isn't enough, and environment is also important. In ITP, the autoimmune reaction to specific self-antigens is platelet specific, but there are 2 complications, which are infection and predisposition to other autoimmune disorders that may be part of the mosaic of autoimmunity. Within 5 years prior to an ITP diagnosis, when patients have not yet been exposed to any immunosuppressive therapies, there is an increment in almost 9 times the risk of having at least 1 hospital visit for infection. And additionally, ITP patients may share a common genetic background that predisposes them to develop other autoimmune diseases during the course of the disease. One example is lupus. It's a disease that has an incidence 27 times higher among ITP patients than in the normal population. So the next question deals with the clinical presentation of the disease. Which of the following is not a frequent manifestation of ITP? A, bleeding. B, thrombosis. C, infection. D, leg ulcers. And the right answer is D. So when we address the patient need for information, that involves telling them what serious complications they may experience. And it includes informing them not only about the risk of increased bleeding, but also about infections and thrombosis. Obviously, the decreased platelet counts increases in about 7 times the risk of serious bleeding, but also that of serious infection that determines that the hospitalization of the patients in 9% of non-splenectomized ITP patients, while thrombosis is observed in about 3% of them. The slighter 2 times higher risk of venous thrombosis is consistently found in ITP, and thrombocytopenia does not protect against this complication, linking with the previous question. However, we can reassure patients that ITP is less of a prothrombotic state than other autoimmune disorders such as autoimmune hemolytic anemia or lupus. And this paradoxical association of increased risk for thromboembolic events in patients with ITP, with thrombocytopenia, might be partly attributable to conventional cardiovascular risk factors such as diabetes, hypertension, or age. And in general, these traditional risk factors for thrombosis are overrepresented in ITP patients, especially in those that develop thrombosis, since in 60% of vascular events, these predisposing factors are present in our patients. So it is important that patients understand that serious bleeding seems to be less correlated with platelet counts than with other physical warning signs. While mucosal and organ bleeding increase exponentially below a platelet count of 10 to 15,000 per microliter, the presence of hematuria can somehow anticipate one of the most feared complications, which is intracranial bleeding. So this can be viewed hierarchically, with oral purpura being the most sensitive, but hematuria being the most specific determinant for intracranial bleeding. And for that reason, ITP patients with hematuria should receive more upfront aggressive therapies. Now, despite severe thrombocytopenia that often accompanies ITP, the bleeding manifestations are not as common in comparison to patients without ITP who have similar platelet counts. Nurses can assess and educate patients about which activities patients with ITP may or may not take part in. For example, shaving is preferred with an electric razor, and a soft toothbrush should be used for mouth care. Still, we should encourage patients to have an active life and participate in sports and exercise, providing information about which sports may be more appropriate based on the platelet counts and stability, as well as on bleeding history. If that history includes many bleeding episodes or frequent platelet fluctuations, sport choices will need to be more conservative. In people with significant bleeding risk, low impact activities, which doesn't mean these activities are low in intensity, can be practiced. However, high impact and contact activities, which may increase the risk of injury and lead to bleeding issues, in general, aren't considered safe until platelet counts above a safe level have been consistently confirmed. ITP patients frequently suffer from fatigue. This highly prevalent and burdensome symptom differs from the normal fatigue experienced by a healthy individual after exercise or by patients with depression. In general, patients with ITP are keen to perform activities, but feel limited to do them. Knowledge on the mechanisms that contribute to fatigue in ITP are largely lacking, but it can be primarily related to smoldering, systemic inflammation, a poor sleep quality, anemia, thrombocytopenia, or comorbidities, and secondarily by reduced physical activity, anxiety, and depression. ITP significantly affects many aspects of the patient's health-related quality of life, which is uniformly reduced to those experienced by patients with other chronic diseases such as arthritis and diabetes. And this is true whether or not the patient is undergoing treatment for ITP. And our patients are most severely affected 3 to 12 months after the diagnosis, when the symptom management, the treatment, also side effects, and mental coping mechanisms may not be controlled. And fatigue in this population does not seem to associate with platelet counts. However, this symptom does not occur by itself, but clusters with others. And higher levels of fatigue consistently associate with a higher symptom burden across all physical and mental health-related quality of life dimensions. Despite the very high prevalence of fatigue in ITP and its negative consequences, the problem is barely discussed during consultations at the outpatient clinic. And one of the reasons may be that even if we assume that fatigue may be a real problem, we still have very few opportunities to help the patient. Now, once the diagnosis of ITP has been established, we have to decide who and what we are going to treat. And most guidelines say that platelet counts should be above 20 to 30,000, since the majority of the people will not bleed if their counts are above this threshold. At the present time, however, we must incorporate in our treatment plan the notion that we have gone from an approach where the most important thing was platelet counts to another in which platelets are still relevant, but also reducing the symptoms that may be associated not only with the disease, but also be a consequence of the treatments. And therefore, although most therapies we know that will increase the platelet count, we have to decide in a specific patient which ones are most likely to improve the quality of life with minimal toxicity. And this individualization of treatment will incorporate the wishes and the preferences of the patient. So the next question related to therapies is which ones should we tell patients to avoid in order to decrease the bleeding risk? A, paracetamol, B, amoxicillin, C, anti-inflammatory drugs, or D, aspirin. So the right answers are C and D. And here nurses can be involved in patient education related to ITP medications and should stress not only the importance of medication adherence, but also review the medications that they are taking to ensure that they are not having over-the-counter drugs such as aspirin or ibuprofen products, which increase the bleeding risk. If the patient is receiving therapeutic anticoagulant therapy, oral or parenteral, then the target platelet count should be above 50,000 per microliter. Now, although the patients report that corticosteroids induce the lowest overall satisfaction among all medical therapies, steroids are still first-line treatment. But since they have a huge impact on patients' health, they should only be used for short periods of time and for no more than 6 to 8 weeks. If there is significant bleeding, intravenous immunoglobulin can also be used. But if we analyze whether these recommendations are aligned to what is really happening in clinical practice, the results clearly indicate a disconnect, since up to a third of patients are treated with steroids for more than a year. And also corticosteroids are the most common treatment for all lines of therapy, even in the 7th line. Minimizing steroid use is already underway, but a shift in the way steroids are being used in this disease is needed in many, many centers. Now, corticosteroids associate with many side effects that can affect the patient's quality of life. but which of the following is not an adverse effect of corticosteroids? A, osteoporosis, B, diabetes, C, weight gain, D, liver disease. So, sorry. It is true that weight gain and also insomnia, risk of high blood sugar, and peptic ulcer may cause some patients to be non-adherent to their medication regimen with steroids. Nurses can help to manage some of these side effects from the steroids by teaching the patients to take their steroids with food, to ensure that the use of a proton pump inhibitor, and assist also with ways to help with insomnia, such as the use of sleeping aids. And steroid toxicity will probably be voted by patients as the most bothersome side effect in their ITP lives. There is often a disconnect between patient perceptions and that of their treating physicians. The frequency and also the frequency of the severe corticosteroid side effects and the risk of bleeding are significantly different between ITP patients and their doctors, whereby patients are really concerned about side effects concerning their physical consequences, but physicians about only bleeding and diabetes mostly. And although we may not be aware of it, previous studies have shown that the overall burden of corticosteroids leads to almost 40% of ITP patients stopping or reducing their dose due to serious distressing side effects. So currently, we should be moving very quickly after 6 to 8 weeks of corticosteroids from first-line therapies with steroids and or immunoglobulins if there is a significant bleeding to second-line therapies. The second-line medical therapies with robust evidence are thrombopoietin receptor agonists or TPO-RAs, which include romiplustim, eltrombopac, and avatrombopag, and also fostamatinib and rituximab. All three classes of agents have very good quality data, and the surgical option of a splenectomy is clearly declining in the last years, and usually it is only offered to patients that fail medical therapies. The mechanism of action of second-line agents is completely different. While rituximab and fostamatinib would primarily reduce the platelet clearance by different means, thrombopoietin receptor agonists would primarily favor thrombopoiesis and platelet production in the bone marrow. Now, in the last decade, the thrombopoietin receptor agonists have deeply modified the landscape of the treatment of immune thrombocytopenia and established also the foundation for many more agents that are underway. Unexpected observations of prolonged remissions after discontinuation of these agents justified an early prescription, and the data on short and medium-term toxicity is very reassuring. Before these agents were introduced, ITP patients had approximately a twofold higher mortality rate than the general population, in part due to treatment-related morbidity. And now these agents have shown to significantly reduce the mortality rate in this disease. This significant improvement in the care of patients is expected to continue to evolve as novel therapies are being introduced. Numerous novel investigational agents are currently being assessed for treating patients with ITP based on diverse mechanisms. And although still uncertain, many of these agents currently under development may eventually provide new possibilities for ITP treatment in the coming years, and hopefully continue to improve the long-term outcomes by increasing the remission rates in adults. So in this last slide, we try to summarize the main changes in the management of ITP patients. these patients, apart from the wishes of having the best medical care, they have the need to know and also to understand. And the fulfillment of these needs highly depends on the communication skills of nurses, medical staff, and also the patients. Nurses caring for patients with ITP often have to help monitor patient laboratory values, but they also conduct extensive patient education and ensure that the medication adherence to prevent complications is correct. Nurses can be instrumental in helping patients address their concerns about their condition, including their activity levels, and also the physical consequences of the disease and of the treatments, and also any possible complications. And I will finish the presentation here, and thank you for your attention, and I'll be happy to answer any possible question that you may have.
Professor Maria, thank you so much for that enlightening presentation. It's like practicing as a hematology nurse, and listening to your presentation gives back a lot of clarification, especially to the questions that you have been inserting in your presentation. I believe a lot of the nurses have some myths that has been debunked, let's say. Doctora, there is a question from the attendees, from Jennifer Bacal. Any comment regarding on this induced ITP in relation to the COVID vaccination, or sometimes from post-transplant patients, autologous patients who had their vaccination, like hepatitis? We encountered some induced ITP. What's going on, Doc? What's happening with that one, and how can that be properly managed?
Any vaccination can induce ITP, and this is especially frequent in children. About 50% of children have ITP either after an infection or a vaccination. So we know for many, many decades that any vaccination can induce immune dysregulation that attacks the platelets. It is clear that after the COVID vaccine, this is a fact that affect about 1 in every million of patients that have been vaccinated. But the rate of this complication is much lower than with other vaccines. And usually this is a disease that is not really severe. After 2-3 weeks, it tends to resolve without major needs other than first or maybe a second line therapy. And it is not a chronic disease in most of the cases. As for immune thrombocytopenia after allogeneic transplantation, yes, thrombocytopenia is a frequent complication after allogeneic transplantation. Sometimes it's immune mediated, related also with graft versus host disease. And sometimes it's only a problem of engraftment. It's a poor engraftment of the cells that have been infused. In any case, when you encounter thrombocytopenia after an allogeneic transplantation, right now, previously we didn't have any therapeutic choices, but right now thrombopoietin receptor agonists, which is usually the first, second line therapy for primary ITP, have shown to be useful and increase platelet counts in about 70 to 80% of the patients. In the majority of the patients, after a certain period of time, we can discontinue these agents, progressively tapering and discontinue the agents, and the thrombocytopenia resolves.
Okay, Doctora, thank you for that one. One more question, Doc. I just noticed in your presentation more of pharmacology approach on the ITP. Any thoughts about autologous transplant for ITP?
Yeah, in some cases it was performed many years ago, and also these patients were treated with high doses. Maybe they didn't undergo transplantation, but they were treated with high doses of chemotherapy, like CHOP, the chemotherapy, or high doses of cyclophosphamide, trying to control that immune dysregulation that was occurring in those, especially T lymphocytes. But usually when you had some responses, it was very transitory and the patients tended to relapse very early. So right now it's not an approach that is followed in anywhere, because we have other medical therapies that really are safe and are effective. So we don't use high dose chemotherapy agents anymore.
Thank you so much for that, Professor Maria. There are no more questions related to ITP. Thank you so much for your time, and inshallah, next time we have a chance again to be graced with your presence, Doctora. Thank you.
My pleasure. Thank you.
Okay, it's 6:40 now. We still have our last, but not the least, definitely. Our last presenter will be giving us a topic in sickle cell disease. Professor Jean Hogdal is a pediatric hematologist, graduated from the Faculty of Medicine of Paris Saint-Antoine in 1997, continued his clinical training in Paris and Lille, France, and Quebec, Canada. After that, a fellowship in pediatric hematology and oncology for 3 years in Saint Justine Hospital. In parallel of that, he obtained a PhD in immunology from Biology Health University School at Lille and in 2005. Currently, a professor of pediatrics from Medicine Faculty at Université de Paris since 2009. He is a director of the Hematopoietic Stem Cell Transplant Program of Pediatric Hematology Immunology Department in Rob Dabra Academy Hospital in Paris. Currently, now president of the Scientific Council from the French Society for Cancer and Leukemia in Children and Adolescent, and member of Scientific Board from the Pediatric Disease Working Party of EBMT, and have been participated in 175 papers indexed in PubMed. Professor Jean will be giving us a pre-recorded presentation, but he is around to answer some questions in related to sickle cell disease. And here in Saudi Arabia, we know our populations of patients. We got a lot of sickle cell disease patients. So nurses, please listen up. And I hope we can give Professor Jean some interesting questions later on. Mohammed, kindly play the video of Dr. Jean. Oh.
Hello everybody, it's a great pleasure to be here with you today in order to discuss sickle cell disease. My name is Jean Hogdal. I am pediatric professor in Paris in France. My conflicts of interest slide. Okay. During long time, probably from the 18th to the 2010s about, we performed more transplantation in children for malignant disease than for non-malignant disease. But recently, this paradigm completely changed, and now, as you can see here, about the French numbers from 2090s, we performed more transplantation for non-malignant disease, 143, as compared to malignant disease, 131, in the French context, meaning that we cure probably better malignant disease and especially acute leukemia with chemotherapy without transplantation, with or without corticosteroids, for example, and we open the windows for non-malignant disease more widely for these recent 10 years, probably. And if we consider the number from the Agence de la Biomédecine regarding the French number for all the countries, you may see that we use both bone marrow, peripheral stem cells, and umbilical cord blood for treating patients with malignant and non-malignant disease from related as well as from non-related donor. If we consider non-malignant disease we treat in my center, for example, in 2016, we performed transplantation for non-malignant disease in 18 patients, among them 5 drepanocytosis, meaning sickle cell disease. And in 2019, we performed more sickle cell disease patients, 13, and more non-malignant disease transplantation. What is sickle cell disease? Sickle cell disease is a monogenic disease, meaning this disease is always related to only one mutation in the gene of hemoglobin. It's a recessive disease, meaning for producing, I would say, a baby with sickle cell disease, you have to have both parents with heterozygous disease of sickle cell. When the patient is monozygote for the disease, in deoxygenated condition, when the level of oxygen decrease dramatically in blood for any reason, you may have a polymerization of hemoglobin. Here you may see on the smears normal erythrocyte, circle 1, where you have as well sickle cell disease, as you can see here, with a very special form with such a needle, and these needles may injure the endothelium. What is the physiopathology of sickle cell disease? The erythrocyte alteration due to hemoglobin F polymerization is only the apparent part of the disease, and this disease is wider and wider than just an erythrocyte change. And this disease presented with multi-step and multicellular process with, for example, platelet and leukocyte activation, abnormal cell adhesion to endothelium, altered vasomotricity induced by decreased availability of nitric oxide, and finally increased hemolysis and increased level of free M in the serum. And at the bottom, you have patients presented with diffuse endothelial and vascular disease induced by both hemolysis and free M. Sickle cell disease is the most frequent rare disease with more than 120 million carriers all over the world. And you have more than 250,000 newborns a world all over the world. In Western countries, as France, US, for example, I would say only 5% mortality were observed among babies with sickle cell disease before they have 5 years of age, with the median age of death for sickle cell disease patients around 55 years. It's far away less than for a general population. If we consider sub-Saharan Africa, half of patients with sickle cell disease will die before the age of 5, and the life expectancy is only 35 years. This disease is, I would say, a recent disease since, as you can see here, the first case was described in the middle of 18th, and the mechanism of the disease was described only in the mid of 20th century, and the real progress in the care of sickle cells appeared only at the end of 90s with, for example, vaccines against pneumococcus or against meningococcus, with antibiotics and with both transfusion program and for sure hematopoietic stem cells. The disease expression differs during aging, with usually vaso-occlusive event during childhood and hemolysis consequences during adulthood. However, there are a huge progress in terms of care and in terms of life expectancy with the neonatal screening, with, as you can see here, a significant decrease of infectious-induced mortality and acute anemia-induced mortality. If we look at the national French program, we now have a 5-year overall survival around 99%. And as you can see here, the numbers are the same in US, in UK, and in different areas in France. However, if we consider event-free survival, the numbers are not so good. You can see here in this curve that you have only 99.5% of event-free survival if we consider vaso-occlusive event, and the number is 60% if you consider acute chest syndrome. It's better if you consider acute splenic sequestration, with 97% of patients with HB-SC with SC sickle cell disease, and 77 for patients with SS. If we consider the different expression of the disease, either acute or chronic, you do not have exactly the same frame. For acute manifestation, you have for sure, you know that, vaso-occlusive crisis in bones, acute syndrome, priapism, strokes, spleen sequestration, as well as infections. Where for chronic, you may have, due to chronic hemolytic anemia and free hem, you may have kidney function injury, liver injury, eye injury, lung injury, heart injury, bone injury, as well as skin ulcers and cognitive and cerebral injury. Meaning this disease is a very multi-organic and very severe disease with aging. The treatment is in frontline symptomatic, with chronic transfusion, with drug against pain, with hyperhydration, for example. And more recently, as I said before, we developed a program of chronic transfusion as well as a transfusion exchange program. We used hydroxyurea with success, and we know that from US studies, we may introduce hydroxyurea very early during the life. For some physicians, hydroxyurea may be used before the age of 1. In my center, we prefer for introducing only around 2 or 3 years of age. However, it's possible for using it very early, and hydroxyurea decreased dramatically the vaso-occlusive event. However, maybe hydroxyurea is not enough to prevent cerebral disease and a stroke, I'm sorry. And more recently, probably for the 19th, we developed hematopoietic stem cell transplantation. However, if we consider the median age or the mean age of death among sickle cell disease adult patients in France during the last decades, we may use that for sure the mean age or the median age increase from 1980 to 1986 to 2003 and 2010, from 23 to 67, as you can see here. However, number of patients dying from sickle cell disease still remain very high and still remain young. This disease, once again, is a very severe disease and multi-organic one, and induce early deaths for severe patients. Then we developed hematopoietic stem cell transplantation from the beginning of 19. And as you can see here, this paper from Walters was published in 1996 in the New England Journal of Medicine. And this paper presented a criteria for transplanting pediatric patient with sickle cell disease, as well as exclusion criteria. And in this paper, authors propose hematopoietic stem cell transplantation for any patient below the age of 16, meaning only pediatric patient with HLA identical related donor and severe disease defined by mainly cerebral disease. And the exclusion criteria were at this time age greater than 15, lack of availability of HLA identical donor, or already severe comorbidities induced or not by sickle cell disease. Still, in 2021, hematopoietic stem cell transplantation still represents the only curative treatment for sickle cell disease. 10 years ago, Mathieu Mercier from US published this very important paper in Blood entitled Allogenic Hematopoietic Stem Cell Transplantation for Sickle Cell Disease, the time is now. Probably this paper claimed it's not time for considering hematopoietic stem cell transplantation not only for children, not only for patients having HLA sibling donor, not for only the most severe patient, but probably offer transplantation for more and more sickle cell disease patients. In 2014, on behalf of Pediatric Diseases Working Party, as well as in Borneo Working Party of EBMT, Emanuele Angelucci and others published this paper about indication of transplantation for both thalassemia and sickle cell disease. In this paper, we indicated that young patients with symptomatic sickle cell disease having HLA matched sibling donor should be transplanted as early as possible, preferably at preschool age. And in this paper, we do not define very precisely what is symptomatic patient. And probably we opened the window to a concept of preemptive transplantation, meaning, okay, do not wait for having a very severe patient with comorbidities for thinking about transplantation. Please consider transplantation very early if you have the good condition for providing it. In the same paper, we said that sickle cell disease, stem cell transplantation from unrelated bone marrow or from unrelated cord blood should only be considered in the presence of at least one of the indications suggested by Walters and co-authors in the New England Journal of Medicine paper I just presented before, and should be performed only in the context of controlled trials in experienced centers. What are the results for sickle cell disease and transplantation when using allogenic stem cell transplantation from sibling donor in young patients? Elian Glickman and others published this very important seminal paper in Blood in 2016 about 1,000 HLA identical sibling transplantation in sickle cell disease from both American and European registries, from 94 centers, from 23 countries. And these patients were transplanted from 1986 to 2013. And as you can see here, the 5-year overall survival are very, very good, 95%. And as you can see, please do not use peripheral blood stem cell for transplanting patients with sickle cell disease. As you can see here, there are huge differences between bone marrow in blue, cord blood in green, and peripheral blood stem cells in red from match-related donor. And as you can see here, regarding the 5-year overall survival, 96% for bone marrow, only I would say 79% for peripheral blood, and 100% for cord blood. There are some primary and secondary rejections. Some patients, few, 29 among 1,000, received the second transplantation, and 62 died after transplantation from transplant-related mortality for 57, from event related to sickle cell disease for 3, and from secondary tumor for 2. If we consider 5-year of event-free survival, the results still remain interesting and good with 80%, but these differences between event-free survival and overall survival represent some adverse event we know in the setting of hematopoietic stem cell transplantation. And once again, results are better for patients who received transplantation from bone marrow or cord blood, and worse when receiving peripheral blood stem cells. When we performed multivariate analysis regarding event-free survival, these results were better for patients transplanted after 20,000 and below the age of 18. The conditioning regimen did not impact the event-free survival. What about GVHD? We have some GVHD in this paper from Françoise Bernaudin and co-author describing the French cohort of 236 patients. We have some acute GVHD, 20% regarding grade 2 to 4 and 5% regarding grade 3 to 4. And we have few, but we have some patients with chronic GVHD, by chance very few with extensive chronic GVHD, and only 3 patients presented with non-resolved chronic GVHD. 2 died from chronic GVHD. But remember, these results are good only because we consider young patients transplanted with matched sibling donor, meaning young donors as well, and using bone marrow and ATG into the conditioning regimen. And it's very important to remember matched sibling donor, young patient, young donors, bone marrow, ATG, myeloablative conditioning regimen. If we look at the chronic GVHD, we may see in the French cohort that the incidence of chronic GVHD dramatically decreased when patients receive high dose of ATG. It's the reason why we still continue for using 20 mg per kg total dose of enzyme ATG in our myeloablative conditioning regimen in hands. And in this paper, Françoise Bernaudin, once again, about the Drepagref study, compared the complication presented by patient who received hematopoietic stem cell transplantation or with a pair-match patient who received chronic transfusion program. And as you can see, we have different complications in both groups. But if we consider the median level of hemoglobin in orange for hematopoietic stem cell and green for a chronic transfusion program, you may see that after transplantation, patients present statistically better hemoglobin level in the arm of transplantation, statistically lesser level of hemoglobin S as compared with non-transplanted patients, and a statistically lower rate of ferritin and iron overload. Then, allogeneic stem cell transplantation from sibling donor in young patients after myeloablative conditioning regimen is the success story of transplantation. We do not have any other disease with such good results. However, some physicians, non-transplanted physicians, still have resistances regarding transplant and toxicity, and we have a lot of remaining questions. How to decrease toxicity for limiting long-term side effects in children, for allowing stem cell transplant in adults with comorbidities. Do we have to expand indication how to transplant patients without sibling donors? However, yes, there are some changes from 1996, and all the inclusion criteria described by Walters still remain accurate, but we probably now consider to cancel all exclusion criteria described by Walters and co-author by conducting cooperative clinical trials with reduced intensity conditioning regimen for older patients with comorbidities and or alternative stem cell sources and or using modified GVHD prophylaxis. What are different ways to expand indications for less severe pediatric patients, keeping the same general frame, meaning myeloablative conditioning regimen and sibling donor? How to propose transplantation for older patients, probably after reduced intensity conditioning regimen, and I will present you very quickly result after 3 grays total body irradiation, alemtuzumab and sirolimus with sibling donor. How to develop hematopoietic stem cell transplantation from alternative source. It's very difficult because unrelated cord blood doesn't work. We know that. Less than 50% of overall survival. It's not acceptable from non-malignant disease. Match-unrelated donor. There are no match-unrelated donor into registries, in international registries for patients with sickle cells. We now have haploidentical experience in sickle cell disease from Baltimore. It's interesting, but it's difficult with some toxicity, death, chronic GVHD, extensive chronic GVHD, infection. Then, okay, it's possible, but probably we have to propose haplo transplantation only for more severe patients because it's difficult. And we have now gene therapy. You may see here in this paper some study regarding reduced intensity conditioning regimen, flu-based, TBI-based. You have some, but as you can see here, there are very few patients in these papers. Recently, in the British Journal of Hematology, colleagues from US and Saudi Arabia proposed this retrospective study about non-myeloablative conditioning regimen from a related donor in sickle cell disease. As you can see, mainly SS patient, but as well some SC or SBT tau. 122 patients underwent matched-related donor, and we have, they described 16 patients with graft failure and 103 patients alive and well with stable donor chimerism, meaning it's an interesting option for using reduced intensity air conditioning regimen. We have now as well gene therapy under development from different pharmaceutical companies with lentiviral vector or microRNA technique. Gene therapy used autologous cells, then there is no risk of GVHD, and a final therapeutic hemoglobin level does represent a challenge. Which level is really protective for vaso-occlusive event, stroke, and long-term multi-organ defect? We keep in mind that using gene therapy is probably as using a chronic transfusion program. You still have patients with some sickle cells and with non-sickle cells, but it's completely different than using donor and allogenic transplantation, because after allogenic transplantation, including after transplantation from heterozygote donor, you have 100% of non-sickle cells. After gene therapy or after transfusion program, you still have about half of erythrocyte able to sickling. And for sure, we have a concern regarding availability and price. And very quickly, we have some concern with the occurrence of myelodysplastic syndrome and acute myeloid leukemia post-gene therapy. 3 recent cases are reported from Bluebird Bio trials, and it's for sure a concern. We are not sure currently that these events are directly induced by gene therapy, since we as well observed some hematological malignancies after a non-myeloablative conditioning regimen from the British Journal paper I described some minutes ago. As you can see here, among 106 patients, 3 presented secondary malignancies, and it's a concern. We do not know why, but we have to consider this risk when we propose non-myeloablative conditioning regimen as well as gene therapy in sickle cell disease patients. However, it seems that sickle cell disease by itself may present a risk of, in this slide, sickle cell disease by itself may represent a risk of secondary malignancies, and we don't know if it's related to therapy of to sickle cell disease by itself. But for sure, patients who receive up to now reduced intensity conditioning transplantation or gene therapy received previously long period of hydroxyurea, for example, and it may represent a risk of secondary malignancies. Then there is no formal conclusion today regarding the risk of secondary malignancies, but we have to consider it for sure. Finally, take-home messages regarding sickle cell disease. Sickle cell disease is a multisystemic life-threatening condition. Hematopoietic stem cell transplantation and now gene therapy represent the only curative options. Hematopoietic stem cell transplantation from healthy sibling donor after TBI-free myeloablative conditioning regimen provides very satisfying results, more than 95% of overall survival, about 90% of event-free survival, and does represent the gold standard for young patients before having high comorbidity score. Other allogeneic stem cell transplantation still remains under development, and the benefit-risk balance has to be strongly discussed within multidisciplinary team. And gene therapy appears promising, but it's just the beginning of the story, and many questions are pending. I thank you for your attention.
Merci beaucoup, Professor Jean. Welcome to Saudi Arabia, Professor.
Thank you for Yes, thank you for your invitation. I am very happy to be with us.
Okay, Doc. I have two questions only, Professor, if you don't mind, before we close the event. Sickle cell disease patient who had a multiple blood transfusion and with high-risk features who is planned to receive allo HSCT, what is the percentage of success to induce a stable donor engraftment? And what is the crucial role of the nurses during the transplantation in regards to the conditioning regimen and including the GVHD protocol for a patient with sickle cell disease?
Thank you for the question. Regarding the risk of rejection related to previous high transfusion program, I would say depends on the blood product quality as well as on the titer of antibodies, direct anti-HLA antibodies. Finally, I would say that usually we do not have a huge trouble regarding chimerism or rejection. For sure, we may use some desensitization program with rituximab or bortezomib before transplantation, but it's finally very rare, and usually we do not have trouble regarding rejection. We have more rejection risk for thalassemia patient as compared to sickle cell, and we don't have many rejection, whatever the trouble of transfusion program we may experience with some patients before transplantation. And regarding the role of nurses for any transplantation, whatever the underlying disease, we all know that the role of nurses is very crucial because they see patients several times a day, and they may inspect the body, the stools, as well the cutaneous aspect. And we all know that usually nurses represent the first signal, the first alarm regarding the first sign of GVHD, and then they may conduct the physicians for prescribing early intervention against GVHD.
Thank you very much, Professor Jean, for acknowledging that nurses really do play a crucial role in a patient care. As I mentioned in the welcome remarks, as I mentioned in the welcome remarks that we are, because I'm a nurse as well, 24/7 unsung heroes. Unfortunately, no food break, no lunch break, no pee break, but we are the wind beneath your wings, doctors. So for the patients, thank you so much, Professor Jean, for gracing the second day of the SSBMT program for the Nurses Day. And hopefully in the near future, we will be able to meet you again. Thank you so much.
With a huge pleasure.
Okay, doctor. Till we meet again. Bye, doctor. Okay. So that concludes our third session this evening. I would like to acknowledge again Professor Jean Dahl, Professor Maria Lozano, and Mr. Luhanga Musumadi for their exceedingly illuminating presentation. It blew up my mind. Actually, all of them, The 9 of them presented their topics beyond my expectation. So Miss Michelle, which is still with me. How are you, Michelle? Holding on. This is 5 grueling hours, but we still have 724 in attendance of mixed healthcare professional workers. Before I give my closing remarks, anything to say, Michelle, for the attendees and the panelists?
Just a huge thank you to everybody for their efforts and their contribution to what has been an incredibly successful meeting. I've been delighted to be part of it. I hope our 723 participants have also been delighted to be part of it. And a huge thank you to our speakers really for making this such a wonderful event and occasion to share practice and to learn from each other. And thank you once again, Annalie and the SSBMT team for inviting us, the BMT nurses, to be present and share this with you. Thank you.
You're most welcome, and thank you very much indeed for the EBMT team making this day really momentous. Thank you so much, Michelle. Till we meet on the next conference. So before I close the program, I would like to thank again the stern leadership of SSBMT, Dr. Ahmed Al-Asfar, and the rest of the officers and the board of members, as well as our collaborating party, EBMT, Professor Nicholas Kruger. Thank you so much, Michelle, for the EBMT president of the nurses group. By the way, my name is Annelia Stanislao. I'm the president for the nurses group of SSBMT, and I'm currently the clinical nurse coordinator in King Fahad Specialist Hospital, Dammam. We will meet again soon for the incoming conference for the ICML, International Conference for Myeloma and Lymphoma by October. It's a hybrid conference, meaning there's a limited face-to-face or on-site attendees. And of course, there's a virtual still as we slowly opening up for this to go back to the, I don't know, not to set into a new normal. For those people who've been asking for their CMEs, it will be added to your MUMARIS by SSBMT. Give them a week or two. It will be added. A total of 14, 8 for yesterday and 6 for today. And for the certificates, it will be emailed to your registered email address. So don't you worry. No need to announce your name. The SSBMT knows that. A big shout out to the organizing team of SSBMT for all their hard work, of course, led by Miss Noor Kaya. Thank you so much, Noor, and the rest of the IT team, the rest of the ladies. I know this is a virtual, but still your effort is felt from Riyadh to Dammam, even until UK. Michelle feels it. So thank you so much indeed. And until next time, take care and enjoy the rest of the weekend. Bye.
Thank you, everyone.